Good afternoon. I'm so pleased to welcome everyone to our forum webinar today. My name is Colleen Berry, and it's my great pleasure to co-chair the National Academy's Forum on Mental Health and Substance Use Disorders with Howard Goldman. This webinar is the third in a series hosted by our forum on caring for people with mental health and substance use disorders in primary care settings. Research documenting worsening mental health and substance use in the context of the pandemic underscores the critical importance of the work of our forum. The mission of our forum is to provide a structured environment and a neutral venue to discuss data, policies, practices, and systems that affect care for mental health and substance use disorders. Our statement of task and the other information about the forum can be found on our website, which you can see here in this link. I want to move quickly to our fantastic sessions that we have lined up today, but let me first take a moment to thank the sponsors of our forum, who are all listed right here on the slide. Without the generous support of our sponsors, none of this important work would be possible. Please note to everyone that the recording of this webinar and meeting materials will be available on the events webpage that is shown right here on the slide. And without further ado, I am pleased now to turn it over to my co-chair, Howard Goldman, to introduce our planning committee co-chairs and the planning committee as a whole, and to kick off our webinar. Howard.
Thanks, Colleen. Welcome to everyone. We're pleased to have you participating in our workshop webinars. My first task is to remind everyone that you will have the opportunity to ask questions, and that includes the participants in our webinar as well as those of you in the audience. I want to thank our workshop planning committee. You probably have no idea how many meetings there were of this group in order to plan what was originally a one-day workshop and then replanning to make it a series of webinars. And this is the list of people that participated in that planning committee. It was incredibly ably directed by our two co-chairs, Deidre Roach and Ruth Shim. Deidre is a medical project officer at the National Institute on Alcohol Abuse and Alcoholism in the Division of Treatment and Recovery Research. And Ruth Shim is a Luke and Grace Kim Professor in Cultural Psychiatry, and she's a professor at the University of California, Davis in the Department of Psychiatry and Behavioral Sciences. Without them, we really wouldn't have had this workshop and series of webinars. So I'll turn it over in the passing of the baton to Ruth Shim for further introductions.
Thank you, Howard. And the Planning Committee has been hard at work over the last 6 months developing and organizing workshop sessions for what was our original full-day public in-person workshop that was scheduled to be on June 3rd. Of course, due to the restrictions as a result of the pandemic, the Planning Committee has converted these workshops into a series of webinars, and our first webinar took place on June 3rd. Our second webinar took place on July 29th, and today is the third and final webinar in the series. We had several objectives of the workshop, and I just wanted to highlight a couple of them, including to bring together a diverse array of stakeholders and experts to explore ways to integrate care for people with mental health and substance use disorders into primary care settings, using 3 example tracer conditions, which were alcohol use disorders, opioid use disorders, and depression, in order to frame the discussion. And also to examine key factors to support or impede implementation of the essential components of care, and ways to support implementation or address barriers to workforce and financing and payment policy incentives. And also to consider the implementation of essential components of care and to highlight evidence-based care models that are applicable and scalable to many settings and varying resources. These webinars will examine approaches to facilitate the delivery of essential components of care for people with mental health and substance use disorders in primary care settings. And I will go ahead and hand the baton over to my planning co-chair, Dr. Deidre Roach.
Thank you, Dr. Shim. The first webinar explored the landscape of evolving models of care, such as accountable care organizations, patient-centered medical homes, and collaborative care arrangements, and how essential components of care for mental health and substance use disorders might be induced for those care models. The webinar also addressed the policy issues related to implementing these models and the essential components of care. The second webinar highlighted the essential components of care for depression, alcohol use disorder, and opioid use disorders in primary care settings, and also identified the key factors that support or impede implementation of these essential components of care. Today's third and final webinar will explore improving the workforce to support the provision of the essential components of care. It will also focus on addressing financing, payment, practice, and systems level issues, policies, and incentives to support the provision of essential components of care. The National Academies will publish a proceedings from the webinar series, which captures the key themes and issues of the discussions across the 3 webinars. This will be available for free download at the National Academies website. We would now like to introduce our moderator for the first session, Dr. Alexander Ross. Dr. Ross is the Senior Behavioral Health Advisor in the Office of Planning, Evaluation, and Analysis at the Health Resources and Services Administration. Welcome, Dr. Ross.
Thank you, Dr. Roach, and I want to welcome everyone to our first of 2 sessions today, and the topic is improving the workforce to support provision of essential components of care. Integration depends on workforce, a well-trained and available workforce. The question today is, can we have minimum expectations for how care is provided for behavioral health services, especially in integrated care settings? And what is the role of workforce training? Building on the 2 forum sessions from July 29th, which were what are essential components of care and implementation of those essential components, our speakers today will highlight one or more of the behavioral health conditions, depression, opioid use disorder, and alcohol use disorder, to illustrate and emphasize how the field can effectively train to provide essential elements of care. Our speakers will present for approximately 7 minutes each. After that, we'll have a panel interaction with discussion questions, and then an audience Q&A. And Dr. Colleen Berry will be triaging the questions, so you can start submitting questions throughout the presentations, and she will then feed those to the panel for our discussion purposes. Let me introduce the speakers for the panel, and I'll refer you to the session material on the National Academy's website for more detailed bios. Colleen LaBelle works at the Boston University School of Medicine Clinical Addiction Research and Education Unit and is Program Director for the State Technical Assistance Treatment Expansion Office-based opioid treatment with buprenorphine program. Phyllis Foxworth is Vice President of Advocacy at the Depression and Bipolar Support Alliance. Carla Cobb is founder and consultant with Capita Consulting. Stephen Ondersma is professor in the Division of Public Health within the Department of Obstetrics and Gynecology in the College of Human Medicine at Michigan State University. And our final speaker in this session, Parinda Khatri, is the Chief Clinical Officer at Cherokee Health Systems, a community health center in Knoxville, Tennessee. With that, I'd like to turn to Colleen for the beginning of our presentations. Colleen?
Good afternoon and good morning. I'd like to talk today about developing a workforce and supporting our health centers across the country. And it's work that we've done here at Boston Medical Center, mainly starting with a nurse care manager model. Next slide, please. I have no conflicts of interest to report. Our funders are mainly the Bureau of Substance Addiction Services, which is our Department of Public Health in Massachusetts, which has supported this work since 2003, as well as support from the ORN, from the Opioid Response Network, where we further expand access and resources and education to our model to sites across the country. Next slide, please. So this just shows the timeline of the work that we've done. So in 2003, when buprenorphine became FDA approved and we were able to get it in a pharmacy setting, we essentially started a program at Boston Medical using the nurse. It was funded by the Bureau as a pilot. And then from there, quickly saw that this was a way to really expand access to getting patients into care. And in doing so in primary care practices in an academic medical center. So we took it to community health centers. We took it to community health centers. The base of our model was using a nurse, an RN level nurse, to support providers providing this multidisciplinary wraparound care for complex patient needs. And so that then developed into 14 health centers, and over time, RFRs repeatedly went out from our state, further trying to support nurses to do the work. And in doing so, more and more health centers got on board. And over time, that model has grown to greater than 40 health centers across the state, where I think we have about 53 health centers in total. And the model has served greater than 20,000 patients in these settings since this initiation. So our health centers have really been the engine to treating substance use across Massachusetts. And this has been known as the Massachusetts model. So there's different models of care depending on where folks are, what needs, what resources you have, and what you can put into your system. But that's how we did it in Massachusetts. And we were able to fund this through the Bureau, and different models of care developed over time. Initially, it was paying for the nurse, and then that went to a unit-based reimbursement. So really trying to figure out, what the levers are and how do you sustain this is what we've done with this. And also integrating the behavioral health component into this over time. As community health centers have integrated behavioral health into their models, this has been a really nice fit in treating complex patients and being able to access those services in real time with real services in the whole team. Next slide, please. So the workforce. So what do we do? Why do we do this work? And what has happened from this? So in doing so, we've seen an increase of greater than 9,000 patients who have been serviced across the state, utilizing this model of care, utilizing nurses, pairing them with prescribers, supporting the prescribers, and also doing the training for the prescribers. So that system we built started with educating and supporting the nurses on a one-on-one or on a health center basis, but then we built a training and technical support across the state so we could support more and more facilities and all providers essentially. And in doing so, we've really found a way to build this network and really expand access. It's been able to expand providers, facilitate facilities, getting them into care, making people feel more comfortable doing this work. And keeping in mind that as our numbers were continuing to grow, we had a 5-year period of time where the funding didn't change. So there were no more health centers coming on board for a long period of time, yet the numbers continued to grow. So people began to feel more comfortable, and they figured out ways to do this and ways to sustain it. It's also, we've worked with trying to get pharmacists involved and other disciplines into care. And it's not just about treating the opiate use. And I think we've all kind of figured that out over time. This is not an opioid epidemic. This is a drug epidemic. So it's treating the whole person, and alcohol has very much been a part of this. And crystal meth in the Northeast now and in other parts of the country for a long time have been part of that. So trying to figure out, as these pieces continue to move, how do we adjust and what do we need to build? And how do we support folks and the workforce in doing this? Next slide, please. And so this shows you, this was just from 2019. So our training and technical support arm has been a really critical piece in how do we keep this going and how do we continue to support. We know that facilities, there's lots of turnover. Community health centers, unfortunately, have a really large turnover. Some folks may go there for a year or two and get their feet wet and then move on, or, people are always moving around. And so if somebody leaves a facility and then a program falls, that's a really bad thing. So it's about trying to train up the whole facility, trying to provide the support. And if not, if there's only 1 or 2 people there and something happens, we have to have a way to bridge that. And so by building this and providing the training, the support, the mentoring, we've been able to do so. This just shows you the health centers and the numbers of trainings that we've done over time. And that just continues to grow. We've trained greater than 2,500 people in 2019, hosting more than 100 trainings. And I can tell you in COVID, you know, there's lots of things that have happened. We've had some silver linings, and one of them has been our reach. Because of the training center that we've built, we've been able to, since that started, we've done over 100 trainings just in that 4-month block of time. So again, we're still able to reach more and more providers seem to be getting engaged using technology, which is really exciting. Next slide, please. This just shows you the numbers of folks that we've trained. We started as a nurse care manager model. We've quickly expanded. We provide training. We provide CME and CE credits to all disciplines. We've engaged recovery coach, peer support navigators, and others that are critical to this work. And again, so we've reached over 12,000 people in the span of time here on the slide, a little over a year and a half. Next slide, please. Using technology, as I spoke about, this is our website, which just shows you, so when COVID happened, how did we adjust and what happened with the racial disparities. So we started providing telehealth trainings. How do we take care of patients at the time of COVID? How do you do this remotely? What kind of tools do you need? What happens to the urine? And then recovery coaches and supporting recovery coaches. And we developed these drop-in sites where the recovery coaches are getting together twice a week, which has been really invaluable to that workforce. And also to all of us in the work that we do and supporting them through this. Next slide, please. This is just a snapshot of showing our calendar and showing the adjustment that we made and the amount of live trainings that we've done, the folks that we've reached, the attendees that have come to them. So more than 3,000 people have attended these trainings in a 6-month period of time. And really trying to, again, adjust and working with the OTPs, trying to help engage the OTP setting into the community health centers and into addiction care, because it's often been a very separate piece. And so we've been working with that as well as women's health. And then for the different disciplines, developing these chat live sessions and as well as educational trainings for them. Next slide, please. So what actions needed? So if I was to say like what I could do to fix things, to change things, to make things better, I would say like leveraging the ORN. So we have this large training system. We've already built a system here in Massachusetts that's a regional training center, so to speak. So if you were to take that and then expand that into community health, into centers across the country, I feel like our reach could be much greater. We could provide evidence-based resources and treatment to folks. We could support the nurses in the workforce and the multidisciplinary component of that, and have online repositories, which is a lot of what we do now, providing all of our resources and apps and algorithms to folks that do this care, because it can be really complicated, but it's not impossible. You just need the tools and the resources and those that are engaged in the work, and really treating the whole person. And so I think that that is a doable thing, in having a center of excellence to wrap around a community would be invaluable. Thank you.
Okay, thank you, Colleen. And Phyllis, Phyllis, you're up next.
Okay, thank you, Dr. Ross. I appreciate this opportunity to share the role of peer support services as an essential component of care in treating mental health and substance use disorders, as well as how these services can support solutions to workforce challenges. Just a real quick introduction of DBSA. The organization was founded 35 years ago on the idea of peers supporting peers as a key component of an individual's health and wellness plan. The movement has led to the integration of peer support services delivered by a certified peer support specialist as an adjunct to clinical care teams. This protocol has been proven to improve health outcomes for people living with behavioral health conditions. Next slide, please. So a peer support worker is someone with the lived experience of recovery from a mental health condition, substance use disorder, or both. They provide support to others experiencing similar challenges. They provide non-clinical strength-based support, and are experientially credentialed by their own recovery journey. Peer support workers may be referred to by different names depending on the setting in which they practice. Common titles include peer specialist, peer recovery coaches, peer advocates, and peer recovery support specialist. But in performing their roles, they inspire hope that people can and do recover. They walk with people on their recovery journeys. They dispel myths about what it means to have a mental health or substance use disorder. They provide self-education, and they link people to tools and resources. One key role is to support people in identifying their own goals, hopes, and dreams, and helping them create their own roadmaps for getting there. Peer support workers practice in a range of settings, including peer-run organizations, recovery community centers, recovery residences, drug courts, hospital emergency departments, and behavioral health and primary care settings. And that's what we'll talk about today. So please advance the slide. So today I'd like to share with you an example of how we are using peer support services to improve outcomes of seniors through a collaborative care model that integrates primary care and mental health care. This demonstration project is a partnership with Facey Medical Group in Mission Hills, California. It's a suburb of Los Angeles, the Ames Center at the University of Washington, and DBSA. The goal of the program is to improve the overall health of seniors by treating their whole health, both physical and mental. A significant strategy for the initiative is to incorporate one-on-one community-based peer support. Success of the program is to be, of the demonstration is to be measured by demonstrating continued engagement with the PCP team, an improvement in the PHQ-9 score, and identification of a health and wellness goal by that peer that the peer support specialist is working with. Next slide, please. So this slide describes the process. The initiative begins with the PCP, who screens all Medicare Advantage patients using the PHQ-9. If the score is 10 or higher, it triggers a protocol to contact behavioral health services. And these services are co-located in the building. So a therapist comes down immediately to the exam room, performs an initial assessment, and introduces the patient to the DBSA Senior Strength Program. If they agree to enroll in the program, the care coordinator meets with them and introduces them to their peer specialist by making a phone call and leaving a voicemail. The peer specialist then contacts the peer they are working with within the next 48 hours to arrange a location and time convenient to that individual to have their visits. So this is not at the clinic, it's at the location and convenient to the person that they're working with. It's very important to note that these are not wellness check-ins or companion calls. Each visit begins with the peer specialist asking the peer to do a self-assessment using the PHQ-9. So this then provides a jumping off place for starting the conversation for that visit. And then the peer specialist, using decisional balancing worksheets and motivational interviewing techniques, they're able then to assist the peer in identifying their own wellness goals and support them in working towards them. The peer specialist, the team, has monthly meetings with the clinical staff to discuss their cases, and the patient continues to see their PCP. Next slide, please. So because of the pandemic, we've had to adapt the program. Program referrals are now coming from behavioral health rather than from that initial PCP visit, just because there aren't just the number of visits taking place right now. The peer support specialist also is no longer meeting with the peer in person, but rather they're by phone or virtual meetings, such as Zoom, which is what we're doing today. Monthly visits at the clinic have been replaced with a monthly phone call. Next slide, please. So establishing a clearly defined roles among all the partners has been a major factor in the program's success. DBSA recruits and supervises the peer specialist and develops and implements the Peer Support Services Program. DBSA also tracks the results in the AIMS CTMS. FACE has been responsible for training the PCPs, training them on what the program was and how to operate the program. And they're responsible for identifying and referring the appropriate patients to the program. And then AIMS provides access to the CTMS, and they host monthly coaching calls with all of the partners, that being the site champion, the peer support specialist, and these champions at DBSA. So we've just completed year 2 of the 3-year demonstration project. Preliminary results show that the peers graduating from the program have had a 57% decrease in their PHQ-9 scores. Next slide, please. So when implementing a peer support program as an adjunct to the clinical care team, we believe it is crucial to use individuals who are certified paraprofessionals. 48 states and the Department of Veterans Affairs have credentialing requirements. Most state requirements begin with completing and passing a peer specialist or recovery coach course. Most states also require an apprenticeship. Many states it's up to 2,000 hours. With the Department of Veterans Affairs, it's up to 2,000 hours. Once the requirements are completed, candidates are required then to take a test. And all states then do also require continuing education to maintain your certificate. I will say that at DBSA, we believe it takes skill, talent, and dedication to provide peer support services. And when delivered by credentialed paraprofessionals, the potential for positive outcomes is great. Thank you for your time and letting me share a little bit about this important work.
Phyllis, thank you. We're going to turn now to Carla Cobb.
Good morning, good afternoon, everyone. Thank you for inviting me to participate in today's workshop and to allow me the opportunity to talk a little bit about some ideas that I have for workforce development. Next slide, please. We know that people with mental health and substance use disorders often have other co-occurring medical conditions that result in them dying years younger than their peers. And this is often due to non-optimal treatment of their conditions. This is compounded by a national shortage of healthcare providers, as you can see in the map from the Kaiser Family Foundation. This shows that we only have about 27% of the number of psychiatrists that we currently need in the United States, and that rate is a lot lower in some parts of the country, those shown in light blue on the map. And HRSA also predicts that we'll have a significant shortage by about 11,000 addiction counselors by the year 2030. In 2018, the National Council on Behavioral Health published a paper entitled "The Psychiatric Shortage, Causes and Solutions." In it, the Medical Directors Institute proposes a number of solutions for the shortage, and among those is to make efficient use of other types of underutilized healthcare professionals with specialty training in mental health, among those board-certified psychiatric pharmacists. Next slide. Clinical pharmacists often have 1 or 2 additional years of residency training and can become specialists in providing direct patient care, including for those who have mental health or substance use disorders. They use an evidence-based process of care known as comprehensive medication management, which focuses on identifying and treating or resolving drug therapy problems. Usually this is for people with complex medication regimens or for people not meeting goals of therapy. They look at the patient as a whole. They look at all of their conditions and all of their medications, whether it's prescribed by a primary care provider or a psychiatrist or another specialist. And they work with the entire team to resolve any drug therapy problems and to make sure that the patient is on the best possible medication regimen that works for them. There are a number of examples of psychiatric and other types of clinical pharmacists working on teams in federally qualified health centers, in the VA health system, and on Project ECHO teams. They provide direct patient care and provide education to interprofessional teams. The VA health system has over 1,700 clinical pharmacists working in primary care settings, including a number of psychiatric pharmacists who work in primary care mental health integration clinics, the IBH clinics for the VA. Project ECHO teams, some include a psychiatric pharmacist, and they work together with the team to help teach and support primary care providers caring for people with mental health and substance use disorders, often in rural areas is where we see them working. Next slide, please. So I want to spend the next couple of minutes talking about how this fits in with the key elements of integrated behavioral health described by McGinty and Dommett during our first webinar. Here I have pulled out some of the elements where I think that pharmacists best fit into the team to help implement those elements. And I'll use a few examples using the 3 conditions that we're focusing on here during this series. When you look at team-based care in the primary care setting, pharmacists can serve as an important part of that team. They participate in treatment team meetings, they review patient registries, and they contribute to case reviews with their teams. For example, if the treatment team decides to start someone on buprenorphine for an opioid use disorder, the pharmacist may help by providing patient education, ensuring that the patient has access, can actually get the medication, troubleshoot side effects, and help monitor for medication adherence. When you look at measurement-based stepped care, I worked at the FQHC here in Billings, Montana for 18 years, and we had a great integrated behavioral health team, as well as psychiatric and other clinical pharmacists on the team. And what we did is the process of care, or stepped care, was that for patients, usually after they had failed a couple of trials of different antidepressants, they would be often referred by their primary care provider to see one of the behavioral health team members. They might, and this we did by tracking PHQ-9 scores. They may be referred to a behavioral health provider for consultation or diagnostic clarification, or they might be referred to a psychiatric pharmacist to work with the patient to look at options for the next steps for treatment. We would look at why the patient failed treatment, taking into account things like side effects, drug interactions, and patient preference, also looking at treatment guidelines to help guide next steps. These are people in the past that may have been referred out for care to a psychiatrist, but now we realize that it's better to provide that care right there in their own doctor's office with the help of the integrated behavioral health team. Next slide, please. When we take a look at the structural elements, you can see that the multidisciplinary team is a key part of this work, and it's needed to support that team-based care that I was describing earlier. Another example that I wanted to share in our FQHC is that patients, when they were discharged from an inpatient stay for an alcohol use disorder, they were often referred to the primary care provider at our FQHC. But before they met with their PCP, they would have a joint appointment with the behavioral health provider and the psychiatric pharmacist. Together, they would review the psychosocial history, make sure that we've gotten records from the inpatient facility. We would get a medication history, and then look at different options for medications used to treat alcohol use disorders, if that was something the patient was interested in. And then together we would come up with recommendations for the primary care physician to consider when they met with the patient. And this really made the work of the physician much more efficient when all this work was done in advance before they met with the patient. Next slide. Finally, we need to improve access to care and outcomes for people with mental health and substance use disorders. We need to make sure that every patient has access to appropriate, safe, and effective medications to improve their chances of success and to decrease mortality rates. But this has to be a deliberate process. When you think about teams, it's not easy. You can't just plunk down members of the team and hope that they figure out how to work together. To make the team as efficient as possible, the team really has to sit down together and talk through who is the best team member to do the work, which part of the work in taking care of the patients, and to establish workflows and to really think about which member of the team is the best to do which parts of the work. I believe that we can help address the workforce shortage by providing a team approach to care and making sure that we use every member of the team to the top of their training. In closing, I'd just like to acknowledge the American College of Clinical Pharmacists and the College of Psychiatric and Neurologic Pharmacists for the work that they are doing and for helping me prepare for this presentation. Thank you for your attention.
Great, thank you, Carla. At this time, I'd like to turn to Stephen Undersma, who is next up. Steve?
Great. Thanks, Dr. Ross, and hello, everybody. I'm glad to be able to talk to you today. As you said, I'm Steve Ondersma. I'm from Michigan State University, and I'll be talking a little bit about how I believe technology can also play an important role in addressing workforce issues in primary care. I should say that although most of my funding is from NIAAA and NIDA and the CDC, I'm also part owner of a company that markets e-intervention authoring software to other investigators. So first off, any discussion of integrating treatment for alcohol use or opioid use or depression into primary care really has to first take stock of the treatment gap. As you see in this slide, which is from a SAMHSA presentation based on National Survey of Drug Use and Health data from 2018, not only is it true that the majority of people don't get care, the overwhelming majority of people don't get care, even though they need services for substance use disorders or even for depression. Not only that, most of those who don't get care aren't seeking it and don't feel that they need it. In the case of substance use disorders, 95% of those who haven't received care despite needing it don't feel that they need it. And so this underlines the importance of addressing these issues in primary care. But it also means that we can't just think in terms of providing services. We have to think in terms of proactively reaching out and identifying people who are at risk, whether or not they present themselves as somebody at risk. And secondly, about motivating them to make changes and to take advantage of available services. So in seeking to do that, one simple answer obviously is to say, well, let's have primary care providers do this. But it's not so easy. So there certainly are successful models of implementation of screening and brief intervention programs in primary care. There's also an awful lot out there in the literature suggesting that it's really hard and showing that it's been much more difficult than anticipated despite being a relatively brief project in and of itself. Number of reasons for this. One is one of time. We're talking about today about alcohol use disorder, opioid use disorders, depression, and those are incredibly important, but they're part of a very long list of other sorts of behavioral health issues or prevention activities that are being also put into primary care, and primary care teams are being asked to provide this work. One really important study back in 2003 from Yarnall et al. In American Journal of Public Health added up all of the United States Preventive Services Task Force A and B rated activities and found that to do them all would take an average primary care provider an additional 4.4 hours per working day. So that's a significant barrier. Part of the problems also is that even though we provide training, they don't always show sustained changes in primary care provider behaviors down the road. Partly, I think, because of what Rich Sates has referred to as role responsibility, the idea that, is this really my wheelhouse? Am I really good at this? Is this really part of what I should be addressing? Such that a recent CDC study from McKnight, Eiley et al. In 2020 showed that 80% of patients who reported binge drinking were not counseled to reduce their drinking. So there are real challenges to bringing this into what are really busy and overstretched primary care contexts. So we have to kind of think, what are our options? What might we do to help with this? And boy, What if there was sophisticated technology in everybody's pocket or handbag? And what if we were able to make software that could ask questions and interact and provide information and send subsequent text messages and interface with the electronic medical record? And then better yet, what if there was a spot in healthcare where patients were just kind of waiting, right? Well, obviously I'm being facetious. We have that. We do have that ability to use that waiting room as a window of opportunity using technology, either introduced by the receptionist or someone else in the care team, or using the patient's own devices, many of whom have their own device, and use that as a window to provide screening and brief intervention, and then provide reports that help that primary care team focus in to kind of pull some of that effort off of them and let them focus on what they do best. We've shown in a number of trials that we're able to have a significant effect on substance use behavior using these approaches. Other investigators have found similar results. More recently, we showed that a study at a women's reproductive health care setting where patients were randomly assigned to either a person-delivered brief motivational intervention, software-delivered motivational intervention, or control, that both of the active conditions outperformed the enhanced treatment as usual condition, and that the software-delivered approach did at least as well and was less expensive. It was more cost-effective than the person-delivered approach. In terms of implementation, what happens when we're trying to do this, relying only on clinical staff, without additional outside funding, without a research assistant there to do all of the legwork? In settings like that, we're finding over 90% of patients are put in front of the technology and successfully use it, resulting in a report going to the primary care team. And we're also finding high ratings from patients in terms of satisfaction with the process. In terms of training then, what this could mean down the road is that we're able to pull a lot of that heavy lifting, put it onto technology in that waiting room area, and then instead of having primary care providers dealing with really an awful lot of information in all sorts of areas, asking them to screen for multiple behaviors and address multiple behaviors, that technology can help them focus and zero in on what's a priority and use some of those skills that are already very, very comfortable for primary care providers, reviewing test results, advising, making a referral for those who are willing to accept that referral. So big issues and big questions here. One temptation is to keep adding training and adding tasks to the primary care team in a way that might not be sustainable long-term. Primary care teams often feel like there's an ever-expanding and shifting list of priorities that they're having to address, in addition to the presenting problems. Technology may be a way to let us zero in and focus and prioritize those a bit in a way that helps us, instead of putting these problems aside, make them more of a focus in a way that's more sustainable for primary care teams. But of course, in that process, we never know what's going to happen. This would be a new approach. We have to keep our eye on, while we're fixing one thing, maybe we're creating new problems. These are all kinds of good empirical questions to look at down the road. Yeah, so that's it for me. Thank you for your time.
Great. Thank you, Steve. So our final speaker is Parinda Khatri from Cherokee Health System. Parinda?
Hello, and thank you. I'm delighted to be here. I am coming from Cherokee Health Systems. We are a comprehensive primary care, behavioral health integrated organization. We're both an FQHC and a licensed community mental health center and a licensed alcohol and drug treatment center. So we like to call ourselves the hybrid safety net. Next slide, please. A little bit about our strategic emphasis, and if you could just click through the different bullet points. Blending behavioral health and primary care is at the core of our mission and our care model. We've been blending behavioral health and primary care since early 1980s. Alex remembers those days. It's been, back then we was just a handful of us integrating behavioral health and primary care. We go where the grass is brownest. That's our motto. And there's a lot of need. We've got beautiful mountains in Tennessee for sure, but there's a lot of brown grass, unfortunately. A little bit about our strategic emphasis. The telehealth certainly has been something now that has been very top of people's minds, but we've been doing telehealth now for 20 years, primarily as a way of enhancing access. Training healthcare providers, and that's what we're talking about today, has been very near and dear to our heart. We've been training healthcare providers for 40 years, and I always say this is the most selfish thing we can do because it is the one way of improving our workforce. You know, it's really hard to get people to come to Tennessee and to come to the mountains and want to work with the underserved. And so we grew our own. It's been the best decision we've made. And then certainly you can't be a large organization and not get into value-based contracting these days and healthcare analytics. So we've had to strengthen our infrastructure. Next slide, please. A little bit about our model, and we'll just go through those bullet points. Like many others who have spoken in these series, we bring together expertise across the continuum. We have a behaviorist, typically a licensed behavioral health provider, psychiatrist, community health coordinator. I'm so glad to hear Phyllis speak and talk about peer wellness, peer specialists. We have them, our peer wellness coaches, peer recovery specialists. We have certification in Tennessee, and we have a wonderful team of peer specialists. They are gold. And I will tell you, for many of our patients, the providers could be on vacation, we could be out, nobody cares. If one of our peers goes on vacation, our patients are like, where did they go? Where is home? It's a really, really wonderful to see the connection that they have with our patients. For us also, the key is the patient feels like they are in one space and there is a seamless flow. So everything is organized around the patient. We have a shared patient panel, integrated record, the flow of care, and a continuum of specialty mental health services. So we do have primary care that is really enhanced by behavioral health support, but we also have a continuum of specialty mental health resources. And I'll give an example of how that works out later. Next slide, please. As I mentioned, we have a long history as a learning health system. We are an area health education center. I was also very excited to see the work in clinical pharmacy. We have clinical pharmacists who cycle through. They have been just wonderful, not just resources, but also we've got a number of wonderful clinical pharmacy-led programs that have been critical to our quality improvement and access initiatives. So we have developed training partnerships with anyone and everyone across the state of Tennessee. We have 25 clinics from Memphis, Chattanooga to Knoxville. We have clinics in the mountains on the border of Kentucky, on the border of North Carolina. So we have patients coming in from Arkansas, Mississippi, Kentucky, Georgia, you name it. And it's really important that we provide really a broad scope of services. Some people, when they've come for 3 hours. I mean, it takes 2 to 3 hours to get to our clinics. And so then now we're able to bring in family medicine residents, medical students, nursing students, psychiatry residents, psychology internship and postdoc programs. This is absolutely critical for us. And I always tell our folks who are training, if you're not going to work with us, we certainly hope that you will go to another safety net setting. There's the pipeline for the safety net is it's narrow, and we need to help grow it. We also do quite a bit of training for organizations. So we recognize that the workforce we have, we could triple our workforce, and it's still not going to meet the need. So we've had a lot of interest in people who are already practicing, who want to learn about our model. Next slide, please. These are some of the core competencies. Over the years, we have learned everybody has to learn how to do assessment and treatment in behavioral health. And by behavioral health, I mean also mental health and substance use disorders. It used to be we asked people, are you interested in substance use disorders? Are you interested? And many people would say no. They would say, I have no interest in it. But then we realized this is critical for every healthcare provider, and it has been a game changer. Every pharmacist who trains with us, clinical pharmacist, actually shadows and participates in our addiction medicine clinic. They participate in our intensive outpatient program for alcohol and drug use. And can I tell you, it has opened their eyes, because they have been on the other side. And now they're seeing the soft underbelly of people who have experienced trauma, who are struggling to, make it through each day. And they will, without fail, come out of it saying, I will never practice what I was doing the same way again. I have empathy and understanding in a different way. The other piece is the paradigm of primary care, which is really organized around, we like Barbara Starfield's 4 C's. So access to care, continuity of care, comprehensiveness. We drum those into all of our students. Access, access, access. We have to go where people need us. And then certainly the attention to the contextual, cultural, and social factors. You can't be in a safety net system or frankly anywhere and not do that. And the team-based care has been something that we have really grown in the past 2 years. There is a really interesting bolus of research in team science and team implementation science. So the very first day of orientation, I tell everyone, your job is to be a good team member. And this is what science tells us that makes a good team member. You could be a great clinician, but if you're not a good team member, you are not going to be able to contribute to the team. Next slide, please. Just a little bit on the kind of strategies we use. As I mentioned, in orientation, we're very intentional about saying, this is our model. This is how we want to train you. We have people shadowing multiple providers. So just because you're a psychology student doesn't mean you're not going to shadow primary care. In fact, you will. We have our psychiatry, medical students shadowing psychology. Everyone gets to see everyone else's role. And I actually think that there's a lot of power in being in a system and kind of absorbing the air and watching people talk with one another. That actually, I think, inculcates a culture in you that you want to build and grow. And I always say that that's something it's kind of like priceless, but being in an environment, and I worry about that now with so much telehealth during the pandemic, but there's something rich about that. Next slide, please. These are just some of the competencies. Like I said, nobody gets to say, I don't do substance use disorders. I don't think any of us can say that in the real world. But we train everyone on our protocols. Population health is standard, substance use disorders standard. Motivational interviewing is something that we're very intentional about because it is what we call a common element across all practices. So we're very big proponents of the common elements model. If you look at all the evidence-based practices, there's certain components that they all have in common, and they can be deployed in clinical pharmacy, peer specialists, psychology, primary care. Next slide, please. This is just an example of how this all pulls together. So imagine if you are a trainee, you may be in an addiction clinic and shadow behavioral health care manager, our clinical pharmacist, and our peer support specialists, our medication, our MAT physician. They all huddle every single morning. Every morning they huddle. Now they huddle via Microsoft Teams. And then they're also then integrating with OB and pediatrics because we have an OB clinic for women who are addicted to opiates and substances. Those women are going to deliver babies, and those babies are followed up in our pediatric clinic. So imagine the intensity of collaboration. So we have these moms coming in, they have trauma, they have addiction. Our addiction medicine team is working closely with them. Our OB team is working closely. When they have the babies, we're bringing in the pediatricians. We've also started having a developmental psychologist in on every one of those well child checks. So you will see that you have a specialty service actually being woven into the broader integrated primary behavioral health care. And then imagine bringing students into that and trainees into that, so they see the intersectionality of all these issues. And I think that's it. Is there another slide? That's my wrap up.
Well, great, Perinda, thank you. And at this time, I'd like to ask all our speakers to put themselves back on their video, take themselves off mute. We're going to have a little bit of a discussion within this panel. And I'm also going to encourage those who are listening today to type in questions into the chat box. Dr. Colleen Berry is available to triage those questions, and in about 10 minutes, we're going to want those questions to share with our panelists as well. So thank you to all our panelists for really enlightening presentations on this broad topic of how do we make sure that when it comes to these 3 sentinel behavioral health conditions, we will have the essential services that are needed that you might be able to expect across our healthcare system through the training and the education that you've described here. And the first question I want to pose to you is, where do you feel we should place additional emphasis regarding training in the future, given what you've been working on, given the issue of integrated care? What do you feel we need to do moving forward differently than maybe we have been doing in the past? And so, Colleen, I want to turn to you first. We've actually had some conversations along these lines in the past, and I'd be interested if you had some thoughts about this. You're on mute. There you go.
Yes. Hi, thank you, Alex. Training the entire workforce is what we all, aim to accomplish here, and training, supporting them, allowing people to work to the scope of their practice, and utilizing each team member to the scope of their practice, I think has huge value. Training them and then reimbursing them for the services and making sure those services align with the parity of other services that are provided. And we can't keep people in this field, and we can't support the services we do if we don't reimburse for them at the same level that we reimburse for other specialty care. So RN level nurses are one great example that I've been, really vested in for a long time, and that there are RNs in these community health centers or in other community practices and in hospital practices that are, well equipped to do this care, and prescribers would be more apt to take it on if they had that support, but it's not always reimbursable. So we are reimbursing in a lot of places for peer recovery coaches. We're reimbursing for social workers, but we don't have the reimbursement for the RN level care to support the prescriber, which could really be a game changer. But also in the other providers in that field, including the pharmacists, which to me is gold as well, to be able to move things forward.
Yeah, thanks, because I wanted to go to Carla for a second on this and ask, do you see a trend here in pharmacists becoming more engaged directly with the treatment team, and what do you see in terms of behavioral health in the future regarding training for the pharmacy workforce?
Yes, thank you, Alex. That's a great question. Pharmacists are often part of the team, as I mentioned, in some of the settings where there is additional funding to help support them. But likewise, as in the RN model, pharmacists are not currently reimbursed by Medicare for the services. In some states, including my state of Montana, Medicaid has now started paying for services provided to patients within a medical office for clinical pharmacists. And so that's been helpful. And so that would really be important in expanding access to this type of care. I also think that we need to expand training. So right now, again, sort of because of the limited resources, we don't have huge numbers of psychiatric pharmacists trained. And much of our training happens in hospitals. Many of the clinical pharmacy residency training programs occur in hospitals and not so much in outpatient settings, where I think that's where, in hospitals, they obviously have team-based care, but not quite like we're seeing in the treatment of mental health and substance use disorders in primary care settings, in particular FQHCs, VA, the patient-centered medical home model that they use, that pharmacists really could be much more part of that team, helping to absorb some of the work that could free up physicians to do some of the preventive care and more acute care, crisis care, if clinical pharmacists could assume some of that medication management responsibility.
Yeah, I like that we touched on the financing in both of your responses. That's kind of like a coming attraction for our next session. You could see how it weaves into even on the workforce training component. Perinda, let me ask you this. You have a very comprehensive approach at Cherokee across disciplines, but what are you thinking about for future training efforts on integration and these essential elements? Are there going to be some changes in the future, some revisions that are supportive of this effort?
Well, and I think it's not so much a change, but really giving greater attention to two things. One, of course, is telehealth, that again, like substance use disorders or some other experiences, it would be more elective, if you're interested in it, but everybody needs to become skilled in how to be a good telehealth provider and that digital literacy. So that's one that is clear. The second is data. And we've talked about this in terms of clinical outcomes. We've talked about this within the context of payment reform and financing, but we cannot let our trainees have their head in the sand about what is being paid attention to. And so very early now, we're saying, listen, this is the data. This is the data we need. This is why, this is the data that we need to share within our teams. This is what we're tracking. And, that's certainly very different than when many of us are training. So I would say telehealth and really the strength of clinical informatics and how we all need to have a baseline knowledge in that, because it's really going to shape financing, and that's going to drive a lot of clinical practice in the future. It already is.
Yeah, it's a really good point about if you want to provide a certain core set or essential elements, teaching benchmarking early on and how you can feed back into your team and the system of care. Right. It's very exciting. Before we move on to the next question, I do want to turn to Phyllis, because it's a terrific model you've described for peers and in depression care management. But how do you see any sort of connection here for opioid use disorder or alcohol use disorder and peers? Can this model be implemented for those conditions as well?
Oh, of course. And as I said on the opening slides there, that these paraprofessionals go by many different names depending on the setting they're in. But for example, I would share with you that DBSA was one of the pioneers in creating a peer specialist coursework. We have a contract with the Department of Veterans Affairs where we train their peer apprentices. That it's a requirement by law that they have training. And it doesn't matter whether that training encompasses substance use disorder, mental health conditions, because at the end of the day, what the peer specialist is doing is they're using their unique lived experience and knowledge of living with a mental health or substance use disorder and bringing that knowledge of how to thrive and live. So it's the same regardless of whether it's major depressive disorder, bipolar disorder, schizoaffective disorder, substance use disorder. And quite frankly, we know that the prevalence of substance use disorders among people living with mood disorders is extremely high. Primarily, a lot of the reason because they're self-medicating before they ever, being diagnosed and getting help for that mood disorder in the first place. So, by sharing their own lived experiences of moving from hopelessness to hope, and because they can share and complement or even kind of replace clinical supports by providing strategies for self-improvement and achieving self-determined lives, it doesn't really matter that the model is the same. It's the individual with that lived experience who brings that credibility to walk alongside another individual.
Mm-hmm.
Great, Phyllis, thank you so much. And I'm going to turn to Steve with our second question, but again, encourage our audience to feel free to type in a question in the chat box, because we're going to open it up for those questions in just a minute. Steve, it's pretty exciting what you described, the changes with the use of technology. Where do you potentially see this going? What could be the next phase after you are able to successfully implement the technologies you're currently working on, what would you like to see down the road on this?
Yeah, it's a great question. I think some of the big picture goals are going to be in a number of areas. One is to keep expanding its ability to address multiple factors. So absolutely, substance use is a major interest for me, as are mental health issues, particularly for myself during pregnancy and postpartum. But there are so many other behavioral risks that we can use technology to reach out, identify, provide some motivation, and then try to make sure that the primary care team has the information that they need. The second thing we can keep doing with it is to keep tailoring it. We can keep making it more and more personalized using language capabilities, using branching, using feedback and results from clinical trials, so that nobody comes to the technology with an interest or a perspective that can't be understood and reflected back. Third, I think what we can do is use all that information to decide how best do we get information in front of the primary care team? What do they need? What do they find helpful? What leads to better results? And in theory, if we have something like this being deployed at a number of primary care settings, we really start having the ability to leverage massive amounts of data, even using decisioning tools and modeling tools to better decide what information do we pass along? What does the primary care team benefit most from? What do they find most helpful? What leads to better outcomes? And in what format do we do it? Again, like I said during the presentation, to try to make it, instead of information design, information overload everywhere, using these design and these user-centered techniques to make it very, very focused and very, very actionable, so that the providers feel more able to do their jobs rather than more overwhelmed.
You know, Steve, thank you so much. And I want to remind folks, my mistake, we're using the Q&A box to ask your questions. So, it's not going to open maybe for a few minutes. Is that correct? Or can you put your questions now? So please put them in now, and then we'll go to them in 1 minute. Brenda, I want to come back to you with Steve's point about the way they're integrating technology. Does that resonate at Cherokee? Are you starting to go down that path as well?
Yes, I agree. I think, that's a force multiplier that I think can have a tremendous impact. And what we're recognizing, again, we're a safety net setting, is that the digital literacy among our patient population is highly variable. And, this is a form in of itself, because we've got patients in the mountains of Tennessee who have no internet, zero internet. We had to create virtual points of access at our clinics for telehealth appointments. And this is where people are literally driving up to the stores, parking there, trying to get internet so they could do virtual schooling. We have patients who do not have any cell phones, or if they have a cell phone, it's a flip phone or a government safety phone where there is no technology. And then we have patients who, we do a lot of school-based health, and we have a lot of teenagers, middle schoolers. The idea of a 45-minute session or a 30-minute session, like that, is not even in their mindset. So what we are really doing is meeting people where they are. And we are seeing people who are engaging in interactive texting, and, we're developing a CHS app for our patients, particularly with addiction, substance use disorders. So they're who are really into it, and they're going to download things and do it. And then we have others. When we checked, 40% of our patients don't even have an email address. So I think, what we have to recognize is there's a significant digital divide. That doesn't mean you don't do anything. That means that you do two things. One is you capitalize and optimize where you can, and then you start where you need to start with a number of people and teach them basic skills. So we've had digital health literacy coaches who are literally saying, this is how you log on to your portal. And they're creating email addresses for people. And that's just one of the coolest things to see, is someone able to log in for the first time, because they've really missed out on so much, that's going on now in our society. It's so tied to digital literacy.
Thank you so much. Colleen, I'm really curious to get your thoughts now. You've been building in the medication-assisted treatment training for health centers and for nurses and other members of the team for a number of years. What lessons have you learned about doing that, and how do you do things differently based on what you've learned?
So again, meeting, like Miranda said, meeting people where they're at, trying to figure out how we get them to the trainings, how we make it so that it's doable in their workforce and with their technology and with their ability to flex schedules. And now we have COVID, right? So initially we had a lot of people showing up at things because nobody knew what to do and they weren't going to work. And now people are going to work and people are doing remote telehealth, which is really draining some folks and is really challenging to be on a phone for 8 hours a day talking to patients and not being able to touch and see and all those other things. So we've adjusted our trainings and going from these all-day in-person formats to 1 hour, 2 hour blocks, 4 hour blocks, trying to make them more interactive, trying to be more case-based learning, trying to bring in panels, using the waiting rooms and the different technologies that our technology gives us. So really trying to find ways to help them get there. We've just developed the 16-hour component that the NPs and PAs have to do. That was all being done online. It was the only format. And we put it into 2-hour sessions once a week at the same time, same station. And then we'll run a second one that starts halfway through that one. So if they miss one. So really just trying to get creative, taking the waiver training and building that into 2 4-hour blocks, which again is a little challenging, but using the chat function and having somebody that mans the chat function while the person's speaking and live answering the questions. So you're not stopping the flow, people are getting their questions answered. So just trying to get creative.
Yeah, it's amazing how these practical issues are so essential, so critical to the success of these kinds of trainings. You know, I want to open it up to the full panel to see if you, hearing what you've heard from your colleagues, have questions for each other. We're welcome to entertain any questions before we do turn to the audience in the Q&A box for questions. Do you have anything you'd like to ask your colleagues? Okay, well, with that, I know
have
Colleen.
one for Carla. Can I ask Carla one?
Oh, please.
How come pharmacists aren't going after trying to become waiver trained? Why is there no initiative to make it so that they can get their X number?
Yes, that's a great question. And the main reason is because, that they have not permitted pharmacists to get an X waiver. And there are some of our national pharmacy organizations that are pursuing that.
Oh, there are. Great.
Yes. And the other limitation is, short of being able to get the X waiver, is many pharmacists have collaborative practice agreements. So we may prescribe medications under the supervision of a physician, but that does not include buprenorphine. So even if you have a collaborative practice, pharmacists may not prescribe buprenorphine under current rules. So that is something that we would like to see changed.
Great, that would be wonderful.
You know, I'd like to loop back to Steve just for a second. The theme of these 3 sessions that we've held, these 3 parts of the workshop, was really about how do we assure and can we assure that there's essential elements of care provided in some standard way, so patients can expect that for these 3 sentinel behavioral health conditions. And if you're able to do the screening and brief intervention, say in the waiting room using a handheld device, that information gets back to the providers. Are there instances now where that's fed into clinical decision support and electronically, and that might be the next or one of the next steps in creating some baseline standards for care through the connection between the expert and the clinical decision support? What have you found there?
Yeah, I absolutely think that's an important avenue for future work. And we're currently doing that on a CDC-funded project where we're implementing electronic screening and brief intervention for alcohol use among women. throughout the Henry Ford Health System. That's a project being led by my colleague, Amy Laree. And part of that project does include using clinical decision support, or in EPIC speak, a brief physician alert, or BPA,
Right.
letting them know that there's a positive score here and providing some very quick tips on how to proceed. It's a fantastic avenue, and I agree, a very important way to take some of these results and put them into the medical record, where we can track it, where we can implement specific procedures that are standardized across these behaviors. One thing we really have to watch out for is BPA fatigue or alert fatigue among physicians. Depending on the specialty and depending on the medical record and the health system, sometimes they find that they're getting too many of these that they're unable to address. Some of them they're required to do something with. So again, I think we have to think carefully about what we present and how much, and the way in which we do that. I think we're going to get there, but for now, that's absolutely an important direction for this sort of work. I would definitely agree with that.
Wonderful, thank you. So, Colleen, you've been tracking the questions coming in. Do you have one to start with you'd like to put out for this group?
Thanks, Alex. We have many, so I'm going to try to move through them as quickly as we can. So the first question that I'm going to throw out is a pandemic question, and it relates to how important is it to see patients in person in primary care, and is integration made more difficult when that's not possible? And I think this both relates to specialty training and the need for specialty training around building an integrated workforce that works in pandemic times, but then also just the interactions of the clinical team itself, not being able to, like, are you doing team interactions in person? And if not, how is that working? And are there best practices?
I see that's resonating with Perinda. Perinda?
Yeah, so is it more difficult? Well, of course, because I think proximity is such a key part of the model, that you are side by side, running into each other, spending time with one another. And in fact, I will tell you, one of the issues that we have been dealing with is how much people miss each other. They just miss each other. And so we are doing physical distancing. Some people are working remotely. Some people, in some clinics, we have like an A/B schedule where different people are coming in. So, each day. So we want the density of the clinic to be much less. And you do have to work harder. We use technology quite a bit. I mean, they first started texting, and they were texting everybody, each other all the time. And now, after a while, we piloted Microsoft Teams, and they've kind of gotten into the rhythm. But it's a different schema that you have to think. But before, you just didn't even think about, okay, I'm going to go say this to this person. And there was almost a very well orchestrated symphony, and there was a muscle memory to that. And now you are building a different muscle memory, like, oh, I may not see this person, but I need to make sure I update on that. And the timing of the flow in our practice, so much of the flow is dependent on the timing of this person sees the patient, then this person, and you're giving feedback, then they're going to go see the clinical pharmacist. And how do you orchestrate that? And when people now, we've done it for a few months, if I get them to try to explain it to me, it makes no sense to me. I'm like, how do you, what? You do this? And they're like, yeah, we do this, this, this. And so they had to reconstruct it. But I don't think they're at the point where it's easy. I think there's still fatigue in that. So you just have to be intentional, absolutely intentional, and realizing that we have to continue to communicate and collaborate. And also, like I said, in terms of support for one another during these difficult times, it's been really critical to maintain some connection.
Phyllis, in the model you described for peers, was that a model where the peer was physically located with where the team was? And do you see now that peers are probably working more at a distance, that could be something to carry on into the future? Are there lessons being learned about that?
Well, that's a good question, Dr. Ross. The intent of the model was to meet the patients where they were at. So rather than having them come back to the clinic, it was community-based peer support. So that peer specialist reached out and said, where would you like to meet? And where that could be at a community center, library, a coffee shop, wherever that was. So when, back in March, we had to contact our peer support specialist and tell them that you can no longer meet in person. Like effective immediately, this needs to stop, and we need to start doing either phone calls or virtual communications. But what was lost was that they would have those those semi-weekly, those weekly and semi-monthly huddles with the clinicians to talk about the peers that they were working with. That wasn't going to happen anymore. There was a lockdown as well at the clinic. So what we have learned is that, especially on our monthly coaching calls, is there's no such thing as too much communication. So when the peer specialist has a concern about someone they're working with, they email the director and the site champion, and she's then able to look into the health records and back. And so in addition to having the monthly Zoom calls where everyone's getting together and meeting, we're definitely encouraging everyone to use that. And we're very fortunate that the site champion also encourages those emails, and she gets back, immediately. But without that over communication, I agree, it would be difficult.
Great, thank you. Colleen, another question?
Yep. So related to this, a question for Steve. Actually, I'm going to ask you two questions, Steve, to address two different questions that were directed to you. The first is COVID related, and it's whether you can comment on how your technology in the waiting room related recommendations are adapted in a COVID world when waiting rooms are a very different experience. And then the second question is more about whether this kind of technology addresses psychosocial, education, or demographic related characteristics of the patient that can be helpful for the integrated team in meeting treatment needs.
Sure. Yeah. Thank you. Those are great questions. In terms of adapting for the new realities and the changed waiting areas, yeah, my work, just like that of all my colleagues, has had to change dramatically as a result of this. Maybe a little less dramatically because we already were doing it in a way that's amenable to the sort of distancing and remote work. Typically, we would hand a patient an iPad that's already configured, give them a pair of free disposable earbuds, and it's all very easy to use regardless of their background. And that kind of gets to the second question I think that you raised. Now we're having to find ways to get it out to them before appointments. So we're either sending links so that they can do it before they come in for an appointment, or the links are being provided in the course of a telehealth meeting so that they can actually do it right there in some cases if it's brief enough, or otherwise be asked to do it before a subsequent appointment. Those have been some of the primary changes, is that we're making it available proactively even before the appointment. In one case, women who are coming in for a new OB intake are asked to come to the door, say that they're available, that they're there for their appointment, and then we have a QR code, a little barcode on the door. The waiting room of this particular clinic is their cars. They stay in their car until they're called to come in. They go to their car, they have flashed that barcode, and they complete it in their car before they actually go in for their appointment. So we're doing it differently in different clinics, but there are all kinds of ways that we've been able to adjust it so that patients have been able to make use of the technology before they get seen. In terms of questions about lower income populations, it sounds like at least part of that is our population's comfortable using technology, if I'm understanding it right. And fortunately, that's not been an issue for us. We've found that regardless of the population, They're extremely comfortable using technology. They're familiar with it. Part of this is a function of the age group that I work with. So age is more of a predictor of technology familiarity than income. So working with pregnant and postpartum women, it's a younger age group, and familiarity with technology is really just universal. If you design it with any sort of attention to usability, we tend to get very good ratings for ease of use, et cetera. That just hasn't been a challenge. In terms of other sorts of risks, I think that gets back to the tailoring that I mentioned. That's one of the great things about technology, is that if you find a particular subset has different needs, has different sorts of issues that need to be addressed, the technology can very easily go down a different path. And the data that you get in droves as you go about this process lets you better determine who goes to what path and what they should receive. I hope I answered this good. Please let me know if there's any aspect to that I was kind of missing.
No, that's great. The next question looks at, in the context of primary care, doing integrated care and implementing integrated care models. The questioner asked about social determinants of health, housing, food insecurity. How do those elements get incorporated into these models? And the questioner asked this specifically related to the Massachusetts model and the Cherokee model. So maybe Colleen and Perinda can begin, and then if other folks have good ways of addressing social determinants of health, they can jump into maybe.
Sure, this is Colleen. I would say, it's a critical piece of the work that we all do, and that if you don't address people's housing and food insecurities, you might as well just go home, because the rest doesn't work. Although we all struggle with the housing, another silver lining, so to speak, of this pandemic there's been more resources for housing. So trying to leverage and take advantage of some of that now has been key. But we have concrete service support within our model that's funded by the Bureau of Substance Addiction Services in Massachusetts, having care managers and having peer recovery coaches and peer navigators. And we do this Thrive screener to assess people's social determinants, and then we find what it is for the resources that we need to leverage. We also provide clothing within our program. We also provide T-passes and transportation, and we utilize our Medicaid system for other methods of transportation, and our Medicaid system for, WIC programs and what have you. But critical pieces, and something we're addressing on a constant basis. And it's often more important than most anything else. It's like, what is their number one problem? Not what is our number one problem on the problem list. What is the patient's number one problem? And that's what we have to address today. And then the rest of it, obviously you're going to work through. But that's what we work through.
Brenda, I think you're on mute there.
Yes. So that we have, if you'll see on our team, we have a CHC community health coordinator. And historically in mental health, they may have been called case managers, but they are they're just geniuses at being able to connect people with resources, acquiring resources. It's the basics: food, clothing, shelter, all those things, help with utility bills, but also they're just, in terms of getting medical equipment and supplies and other things that people need, they really are the brain trust. And they also, 50% before COVID of their work was to be outreach. So they would go into the people's homes, they would go with them to appointments, they'd gone with them to court dates. So that's been important to have that on our team. The second thing that's been critical has been partnerships. And we talk about things within the system, and we have food pantries in all of our clinics. We do have a couple of buses. We just bought a mobile clinic that we're very excited about. But really, there are community partners who can help us. So we partner with food banks. So for example, every Saturday, we have a food bank that comes to our clinic and just has huge boxes of fruits and vegetables, and we advertise it. And So it's something that we help them do, and our folks staff and volunteer, but they're the one, they're bringing trucks and trucks of food and vegetables. Some of our clinics are in food deserts. So this is huge. And that's nothing, we would never have the capability of doing that. Just never. So we thought, okay, let's partner with someone. And so that's one thing I think that it's really interesting to think how much we think, okay, how much do we do ourselves? But how much do we say, you know what, I've got this, partner down the street. Why don't we help each other? And that's something that when we think about integration, I think it's also very important to keep in mind, is not everything has to be in-house.
Great. Colleen, why don't we keep going? Oh, I'm sorry, Phyllis, did you want to add?
Add to that, I personally have been humbled and honored to see the success of that peer support specialist in that role. I mean, we have we train veterans who are out there working, especially with the homeless population. And one of the roles of that peer support specialist is, key to what they do is providing strategies for self-empowerment and achieving self-determined lives. And when they're working with someone who's walked that walk and is able to give them that hope and inspiration, it can make a huge difference in alleviating some of those social determinants of health, because they're now recognizing what kind of life they want, and they're getting the support and the strategies to attain that life.
Thank you. Colleen, I think we have a number of questions there. So would you like to go on to another?
Yep, I have a bunch still, so I'll try to move through them. Colleen, the next question goes to you, and it's for a reminder, first of all, of sort of the rules around the maximum number of patients that different providers can work with, can prescribe to, and the specific types of professions that can do this work. But then also the second part of the question relates to sort of what we can do from a training standpoint in terms of those maximums. Sort of, are those regulated numbers optimal? What do you recommend in terms of training providers to do office-based prescribing?
So there are federal requirements and federal mandates, so you can't go above them. If you're in a practice setting, that's an inclusive practice setting that's wraparound care. Your prescribers can literally start out at treating 100 patients. If we did what Perenda talked about, which is what we should be doing, and that's everybody should be treating people with substance use and mental health use disorders, then we wouldn't have a problem. And so if everybody just took on a piece of this and treated their patients, I don't think that those numbers would really factor into any barriers. They don't factor into a barrier in the community health centers in Massachusetts or in our practice, because so many people are vested in the work. And once they see patients, and we were spoken about earlier, when they see people get well and they see the other side of it, and not just people in the ED, it makes a difference. But it is 30 for somebody not in a wraparound practice, 100 for somebody who is, or 100 a year later, and then a maximum of 275. But you have to be in a practice that provides all the levels of care and 24-hour services for your patients, like an FQHC practice setting.
And for Carla, one of the questions that came in relate to scaling up clinical pharmacists to do this integrated behavioral health work. Specifically, this questioner noted that these services aren't available in the area where they live. From a policy standpoint, what can we do? And are there resources to point families to that are interested in accessing pharmacist team members?
Okay. Yes, good question. And as I mentioned earlier, some of the biggest barriers are adequate payment for teams that include clinical pharmacists on the team, and training programs. We have large numbers of clinical pharmacists, something like 30,000 board certified clinical pharmacists, not necessarily specialists in psychiatric pharmacy, but who practice in outpatient setting, board certified ambulatory care pharmacists or board certified psychotherapy or pharmacotherapy specialists. as I said earlier, many of those, for somebody who's looking for that type of service, I would recommend trying to identify a federally qualified health center, a community health center. That's where I have seen the largest number of clinical pharmacists embedded outside of the VA system, or as somebody else in the chat also mentioned, Indian Health Service has a very robust clinical pharmacy program. So if you have access to one of those types of services, I think that would be most helpful. I think as far as scaling, one of the things we really need to look at is the use of technology. Given the limited number of psychiatric pharmacy specialists, especially in rural areas, but as somebody else pointed out, that there are plenty of urban centers who don't have access to psychiatry or psychiatric specialists. So, getting more access to someone with those mental health specialty skills, telehealth would be very helpful to reach out to those rural areas, using things like Project Echo to help support providers in rural areas who are serving these populations. One other thing that I wanted to mention was the collaborative care model, which is a nice model. One of the limitations for us here in our rural areas is that a psychiatric pharmacist is not allowed to serve as the psychiatric specialist on that team. And so that is something that would be helpful. We're not able to bill using those collaborative care model codes unless we have a partner psychiatrist on the team or psychiatric nurse practitioner, but a psychiatric pharmacist may not serve in that capacity. So that's one of the things that may also help increase and be able to scale those services.
Great, thank you. So we have a question from a participant who is a family member of an individual, a loved one with severe mental illness and substance use disorder, and that loved one is in a state hospital, and this participant is struggling to get care for their loved one. And there's a financing aspect to this question that I'm going to put off to the next panel. But I think the participant's question really points to this larger sort of organizational challenge, which is we have patients on a spectrum of severity and need. So what is the proper role of the primary care sector, and how can you build a workforce that's working with the specialty sector and sort of identifying where the right setting is to meet the specific needs of an individual patient on the basis of severity?
If one of the panelists wants to answer that, just raise your hand or take yourself off mute.
I think Phyllis, are you?
No, I'm not a primary care physician, so I don't think that would be appropriate for me to answer that question.
Brenda, any thoughts on this?
Well, I mean, I think it really speaks to how challenging it is to navigate our healthcare system, and how finances and silos make it, particularly if you're a family member. I mean, it's a maze. And, many people who are in healthcare, when we have family members struggling, we can tell you it's not that much easier for us either. We're calling, navigating. So I think it really is a structural problem that the fragmentation and the financing are not patient-centered, they're not family-centered, and for this person, it's just so painful, to read about what you're going through, and I hate to say it, but there are a lot of people in that situation. If someone is in a psychiatric state hospital, I typically say to connect with an advocacy group like NAMI or other advocacy groups to see what resources are available. I don't know what state this person is in, but typically every state has a mental health association that has all the community mental health centers are part of that. And there's also a primary care association that has all the FQHC's primary care as part of that. But if really the angle is advocacy and finding a way of a path to treatment that's more long-term on an outpatient basis, I would say find a patient advocacy organization to connect with and to help you navigate. But it's not easy. Your experience, unfortunately, is all too much. Yeah.
The information flow itself is just so critical and such a challenge. Colleen, did you want to add something quickly, or?
Yeah, no, I would just say, I mean, CFR 42 hasn't made this any easier, unfortunately, but there are changes coming to that. And the pandemic, again, another silver lining, has made some of that easier. But being a family member that gets involved and gets engaged and signs those releases and is part of those family meetings and it becomes part of that plan while they're there and the aftercare is critical. Having your voice at the table, and don't ever dismiss that because of its huge value. And then finding the organizations within the state. You know, is it DMH? Are they competent? You know, what other services do they need? And how do you build all that before they get out? And engaging the providers. But you've got to get to the table and pull those meetings together. It's a lot of work and it's a very fragmented system, but it's doable.
Colleen, we have time for one or two more.
Yep. So the next question actually picks up where you just left off. And the question relates to the role of family members on the integrated care team. Sort of what is the appropriate role for family members, and what are best practices?
I can take a stab at that question, Dr. Ross. I think it's a very complicated question because, it's proven that those individuals who have support from family members do have better recovery outcomes. But that also has to be balanced with what it is that the patient is seeking. There could definitely be reasons why that patient doesn't want their family involved. And that can be very painful for the family member when they see things that ways in which they can help, but they have to acknowledge that my loved one has their pathway to journey, and I have my own pathway to journey, my own pathway to recovery, and I have my own journey to recovery, and those might be very separate journeys. And so, while ideally the individual living with the mental health or substance use disorder wants their family engaged, we also have to accept that they may not. And that becomes, at the end of the day, the journey of that patient themselves.
You know, I just noticed we actually have 10 minutes, so we could take a few more questions. Perinda?
No, I just wanted to add, we've had very good success with, it's actually a peer position that is certified in the state of Tennessee, and I believe Maryland and a number of other states. It's a family support specialist, FSS. And that family support specialist is typically a parent who has a child who had been diagnosed with a mental health or substance use disorder problem. They go through the same kind of training, and they really, honestly, they really are like the navigators. And they are hired, we have them, you have them in the system, but they have that family role. And I think they may be able, sometimes a family member, when it's the patient's family member, it's kind of like, well, when your mother says it, you feel, I don't want to, listen. But if a family support specialist can say, this is how this is impacting your family and this is why. So a lot of it is that communication and context. So I hope that is a position and a role that gets expanded and enhanced, because particularly in our work with children and adolescents, that FSS has been really useful.
Colleen?
Yeah, then the next question goes to anyone on the panel, and it relates to a request for advice on building strong primary care-based integrated clinical teams and the role of training, sort of the science of teams and the role of training in allowing somebody to function well on a clinical care team.
I'd be happy to try and answer that if that's all right. Yes, and as I mentioned in my remarks, I think it's really important that as we integrate new members onto that team, that the education has to be bidirectional. Many behavioral health providers are not used to working in fast-paced primary care clinics. Many primary care physicians are not used to working with and now as more and more training is interprofessional, we're seeing that grow. But many didn't grow up with working with other members of the team, and so it has to be very intentional. Really have to sit down and think through. In the example of clinical pharmacists. Usually there are a limited number of clinical pharmacists on the team. So things like which types of patients are best to refer to a clinical pharmacist. They can't see them all, nor do they need to see them all. So what are the developing criteria to say who would benefit from the most from seeing that other member of the team? Communication is super important, as we talked about, using a single medical record, but how do we, step by step, saying how do we communicate? Do we assign notes to the physician once we've seen a patient, or how do we do that? Does the clinical pharmacist have a collaborative practice agreement with that patient's physician so that they can implement any changes at the point of care? Or do those recommendations need to go back to the physician to then implement at some later date? What is the preference of the team in doing those kinds of things? So workflows, I think one of the most important things is many people have not had an experience of having a direct patient care visit with a pharmacist, so don't really understand what is it that they do. That's different than a pharmacist they may see in their community pharmacy. And so teaching nurses or physicians how to explain, doing a warm handoff is often very helpful, so that that we can go in there and explain to the patient, whoever that team member is, see them, get to know them. The rate of the return to a future appointment is much higher if we use that process. And so those are the kinds of things that really have to be deliberate in making the team work most efficiently and effectively together.
I know that we have other colleagues who can, weigh in on this, but maybe to make sure we can get through some other questions. That was pretty comprehensive. Maybe we can carry on to the next question.
Yeah, Phyllis, in your comments, you talked about credentialing and certification requirements. So the question goes to sort of the appropriateness of the level of certification and training for a peer specialist, and I think wanting you to comment on, do we have sort of the right regulatory model in place? And if not, do you have recommendations?
Yeah, one of the challenges is that we have with regards to peer support specialists or recovery coaches is that every state has their own requirements. So there's a myriad of regulations. At a minimum, all the states require that you take a course, but there's no requirements around what's in that course. For example, the DBSA course is 76 hours, and it includes things like motivational interviewing, how to use SMART goals, and how to use decisional balance worksheets. It's giving them train on the tools. Whereas other courses, they're more peer empowerment courses. How do you find your voice? There's, maybe only, 2-day course. And those are important, but those aren't the same as training an individual to be providing these services in the way that they're provided out there professionally. So one of the barriers, I think, for the profession is getting some standardization around what is the floor of requirements that someone is going to be a peer support specialist or recovery coach. What is the bare minimum of requirements that they should have? Because certainly we understand that states have their own, want their own credentialing. But if we had a minimum because one of the other challenges is that people can't move from state to state. So if you're in a border state, for example, like I'm in Chicago, well, we're bordered by both Indiana and Wisconsin. So you can have you can be credentialed in the state of Illinois, but then you move across the state, or you have a job opportunity in Wisconsin or just down the street in Indiana, you can't take that. So there's a, I think as the profession coalesces around being a bona fide paraprofessional profession, these are the challenges and hurdles we need to address.
That's great. Thank you. So the next question goes to Colleen. Colleen, you had described the RN as the basis of your model. Why and why is that an important component?
So when we started doing this work, it was in 2003, and it was really complicated, and most folks didn't have very much of a knowledge base on substance use disorder, let alone did they really treat it other than say, go see your case manager, which is what they were called back then. So by putting nurses and building a model similar to what we did with HIV, we were able to take nurses, let them work to the scope of their practice, and then providers were more apt to come on board and take care of complex patients in their very busy medical practice, where they just didn't have the time to deal with those social determinants and all the other issues that were going on in the behavioral health piece. So that's why we built it. But I just want to say, like, we're talking about workforce. How do you hold them? How do you sustain them? How do you keep them there? And I mean, we need to take care of the people we have, and we need to help them feel good about the work they're doing and help them grow. And I can just say in our practice, amongst 13 RNs that we have taking care of our 900 patients in our one area, 6 of them are in school for their psych NP. You know, and I think that that's really super important, but it really speaks to their commitment, but as well as our ability to support them to go to that next place. And 11 of them have become certified as addiction nurses. So we have to find a way, how do we take care of our workforce? How do we engage people in the care? But it's a model that works in trying to get more people treated without burdening the health system more.
Alex, I'm going to ask 2 questions to try to slip some additional ones in our final minutes. Absolutely. Very quickly, Phyllis, there's a question about where to find the courses to begin training as a peer specialist or peer navigator. And then also, Perinda, there's a question related to the term that you use, learning health system, wanting to know what it is and how does it relate to building and training a workforce that can do this kind of work.
So I will share that, you know, I would start with your state, because as I said, every state has a separate, you know, their own individual credentialing requirements. So I would like to, you know, say, well, sure, come to DBSA and take our course. You know, we're not credentialed in every single state. And so that's the place where, you know, I would never want someone to take a course and then say, wow, it didn't apply to my state. Start with your State Department of Mental Health and look, you know, on their websites and look around, what are the requirements for being a peer support specialist or a recovery coach in your state. And it might not be called a peer support specialist. It might go by a different name. So for example, in Illinois, it's called certified recovery coach, certified support recovery coach. So be looking for those type of language, but start with your State Department of Mental Health to understand what the requirements are before you investigate coursework.
Perinda, the learning health system.
Learning health system actually was taught that by Dr. Frank Degree, who was one of the first speakers and a dear friend and colleague of mine. But, you know, it really, I think, speaks to really a culture and a psychological mindset that, yes, our number one mission and goal is to provide care to patients, but also within that, we want to be a system that teaches, that educates, that is invested in building a workforce. And so that then I think becomes a compass to guide you in everything that you do. How can we embed that process in every clinical initiative, any organizational initiative?
Well, Colleen, Barry, thank you for asking those terrific questions on behalf of the audience. And I want to take this opportunity to thank our panel, Colleen, Phyllis, Carla, Steve, and Perinda, for a really enlightening session. And with that, I think I'm going to turn it over to Howard to introduce our next facilitator. Am I right?
That's correct. I'm back for one reason and one reason only, other than, of course, to hear the next session. It's my pleasure to introduce Richard Frank. He's a professor of health economics at Harvard Medical School, and he and I have been colleagues and friends for more than 40 years. Richard, over to you.
Howard was 9 when I first met him, and
Not true.
and brilliant then. In this section, we take up a set of issues that sort of challenge what we believe and what we've learned, hopefully. We've long believed as a field that some simple policy fixes would go a long way to promoting integration of behavioral health and other types of medical care. Today, what we're going to do is we're going to focus on what we need to understand beyond those simple fixes to advance the goal of integration. And we have a terrific lineup of people who are going to take us on that journey. The panelists for this session are 4. The first one is Dr. Robert Phillips, who's the Vice President for Research and Policy at the American Board of Family Medicine. He will be followed by Sharon Reeve, who is a senior scientist and the Deputy Director at the Institute for Behavioral Health at the Heller School at Brandeis University, and a colleague and collaborator of mine. Kirsten Baronio, who is Director of Policy and Regulatory Affairs at the National Association for Behavioral Healthcare, and who until recently was a senior advisor in the Medicaid program at CMS, who really oversaw efforts to integrate. And then finally, David Smith, who's the CEO and founder of Third Horizon Strategies, a group that has really been focused on developing payment systems that promote integration. With no further ado, let me start by turning it over to Robert.
Thank you, Dr. Frank. I'm Bob Phillips. I'm a family physician. I'm still in practice and working for the American Board of Family Medicine and the Center for Professionalism and Value in Healthcare. And I want to start just with a little context. I finished residency training in 1998 with a cohort of physicians who were not allowed to put a mental health diagnosis down as part of our billing. In fact, if a mental health diagnosis was listed, it invalidated the entire billing. So you had a whole generation of family physicians who were acculturated to not actively diagnosing mental health, even though we treated it on a regular basis. And in family medicine, mental health is baked into the curriculum. It's actually a requirement of residency training. So as I was leaving training, we had an integrated psychology education program into our training sites, along with the psychologists who were faculty who were overseeing them. And because of a payment issue and faculty oversight issue, had to divorce the two and removed a considerable amount of opportunity, not only for sharing patient care, but for learning about behavioral health. Next slide, please. As I moved into community-based residency training program just outside of Washington, D.C., we had 3 integrated psychologists, we had a PharmD, and we had a PharmD education program. And all of those are gone, largely because of the payment model that won't support their being there. And so we've actually had to develop alternative ways of making sure that our trainees are getting exposure to not just psychological care, but how psychologists address care and can be a partner. If you look at the National Health Interview Survey, the data on the left, and looking at patients who report using an SF-12 mental component score, either being in better mental health or poor mental health, almost half of all of those people only get care in primary care. For those with a worse mental health score, there's about 5% will get care in mental health only, and then about 14% will get care in both settings. So there is a lot of, I wouldn't even say a lot of care being provided there for mental health. There are a lot of people with mental health issues being cared for in primary care alone, and not nearly enough overlap, particularly for those with severe mental illness. And the latest data I could find from Medicare about the provision of care for patients with depression was from 2000. It was a 2006 paper showing that almost 2/3 of all elderly patients visits for depression were happening in primary care. So there is a large volume of care and people potentially cared for that are coming through primary care. And it would be so much better, as the last panel was very clear about, if behavioral health and substance use disorder care was integrated here. I'll also tell you that about 10% of our graduates of our training programs, when you survey them 3 years out, and we have about a 70% response rate on that survey, so it's fairly robust, 10% of them not only have buprenorphine waivers, they are actually actively caring for people with opioid use disorder. It's a very small number of programs who produce those 50 to 60 graduates a year. They also happen to be one of the largest workforces taking care of mothers with substance use disorder, and able, as Dr. Prinda was telling us, are able to care for them not only prenatally but postnatally as well. Next slide, please. Sanjay Basu, with colleagues at Harvard, produced a study 3 years ago using a microsimulation model, just trying to see, could you make integrated behavioral health financially viable? And they looked at both a collaborative care model, where you have nurse or master's level behaviorists taking care of referred patients by phone, and you have the primary care physician managing them in person and providing their pharmacotherapy. So it is a partnership, but it's not the ideal partnership. I think Phyllis was talking about earlier, where you have someone down the hall that is immediately available for a consultation or even a warm handoff of a patient with behavioral health needs. And then they also looked at primary care behaviorists embedded in primary care training sites. And what they found is that the second model, the embedded model, was not financially viable outside of an FQHC. The collaborative care model was, but it, as you heard in the last panel, the FQHCs and mental health centers are where the model is working best, and it makes me extremely jealous. Next slide, please. And in just in case the microsimulation model wasn't enough, Brenda Reese-Brennan, who helped develop the integrated behavioral health model for Intermountain Health, published just a few years ago a retrospective cohort study looking at patients who went through the integrated behavioral health model versus those who went through usual practice. And what they found is that those folks in the integrated behavioral health model had fewer ED visits, lower hospitalization rates. So there was a total overall cost savings, and they had better quality of care. But the practices who had those models working received less reimbursement than the models of usual care. Less reimbursement, even though they had invested so much in developing that embedded model. And Tom Schwenk from the University of Nevada, in commenting on this in JAMA, said, you know, the integrated mental health primary care model is the right thing to do. It results in tremendous benefit, financial and otherwise. But the real benefit, the cost benefit, accrues to the employer or to the insurer, not to the practice that's bearing the expense and reduced reimbursement. So the model that works so well that we just heard about in the last panel, we can't get to for the other 90% of people who are cared for outside of the safety net. And in a fee-for-service model in particular, it's very difficult. So we need to find payment models that will support the integration of behaviorists and opioid use disorder therapies into primary care more robustly. And I'm interested in hearing from the rest of the panel. I'm co-chairing a consensus study on implementing high-quality care in primary care. And if you look at our statement of task, integration and payment are very much part of what we're supposed to be looking at. So I look forward to learning more from the rest of the panelists. Thank you.
Thank you very much, Robert. That's a great way to kick us off. It was sort of brings us back to exactly why the simple fixes that we had been thinking about for a long time have been somewhat disappointing to us. Let's turn to Sharon now.
Great. Thank you, Richard, and thank you for having me on the panel. I'm going to provide a higher level look at the role of delivery systems in moving more fully towards integrating mental health, substance use, and primary care. I'd also like to thank the first panel who noted many of these issues in their individual innovations as well. Despite, next slide, please. Despite some important examples, such as prescription of antidepressants or screening for alcohol problems, we know that integrated mental health and substance use treatment with primary care is still not the norm. Frequently, when we talk about new practices, uptake is considered through an adoption of innovations framework, highlighting, for instance, how the innovation's relative advantage and complexity would drive the decision at that setting to integrate care. This model usually informs change by individuals or entities such as primary care practice, yet it's not sufficient as it accounts for those values and that decision-making at an individual level, when there are excellent high-level reasons for moving away from the current standard of siloed care. If we want to drive systemic change, a system-focused framework is needed. Greenhall and colleagues emphasize that innovations to be incorporated widely require broad attention to a resource system that provides financial, regulatory, management, and other supports, to change agents or champions who provide specialized expertise and advance the cause, and to a focus also on the outer context that may provide a springboard or affect whether the innovation is feasible or sustainable at this time. Next slide. Delivery and payment systems can facilitate a move towards integrated care, and in doing so, they also address systemic barriers. For example, development and support of integrated care models at the system level highlights their value to the delivery system as a whole, which can also help to reduce stigma. Availability of system-wide training, technical assistance, or expert support models, as we heard about just recently, could be used to address the off-cited barriers within primary care settings of lack of knowledge or confidence about mental health and substance use disorders, providing support and reassurance, particularly in early phases of adoption. Others will talk more about payment, but funding and incentives are essential tools to support system change. Incentives can serve as a carrot or as a stick to encourage use of integrated care by primary care practices. Supporting the infrastructure itself for integrated care also serves to reduce silos and encourage collaboration and holistic care. And with regulatory and financial issues presenting barriers to sustainability, systems can wield greater power than individuals or practices to address these concerns. One can consider, for instance, how many innovative models start under Medicaid 1115 waivers, which address financing and delivery system changes together. Next slide, please. Change at a systemic level requires both delivery and payment system reform, which together determine access to care, quality of care, and ultimately health equity. These systems are intertwined, and effective change must address both. For instance, access to integrated care may be available with a delivery system, but if same-day visits are not allowed by the payer, it reduces access. Or the example that Bob just gave us about primary care not being able to do mental health. Similarly, providers must be paid for these services in a sustainable way, or they won't offer truly integrated care. Further, quality of care always remains at the forefront, and delivery systems can set goals and incentives to encourage the use of high-quality integrated care. However, the quality metrics and data used in the separate primary care and specialty systems may not remain the same when we consider integrated care systems. Next slide, please. As noted in the traditional adoption of innovations framework, there are broad facilitators of change that also matter for delivery systems. Champions are necessary for any innovation within settings and practices and across systems or payers. You must have champions at the system level as well. In particular, for mental health and substance use disorders, where stigma remains present at all levels, including providers, the champion can raise awareness, be a role model, share knowledge, and so on. Delivery system champions must engage with the practice level champions to ensure that change diffuses within the setting. We know that there is tremendous variation across practices and settings, not just in their organization, but also in their knowledge level, willingness, and capacity to implement integrated care approaches. By creating systems that allow flexibility during implementation, the likelihood of success may improve. Flexibility also highlights the building upon what has already worked within a setting or group of practices, increasing the likelihood of provider buy-in or stakeholder engagement for the next stage. Finally, many interventions are successfully implemented, but without considering sustainability, they do not last. In particular, for integrated care, as others have already mentioned, we must consider reimbursement issues and funding for non-billable infrastructure such as care managers. Next slide, please. On the flip side, there are systemic challenges as well. It's essential to understand that there's not just one system, and this means that the influence of any one payer or healthcare system may be low within any given primary care practice. Multi-system approaches would increase influence and likelihood of successful change. But multiple players also refers to the type of systems, such as social services or specialty care, each of which requires relationships with the integrated care setting and an understanding on that side of how these other care systems work and how to engage patients in need. Another concern with delivery system approaches is that when system-level interventions are imposed from the top down, they sometimes do not diffuse to direct care providers. Or they may diffuse and be incorporated in name, but not fully into practice. An example from OUD is only offering referral for buprenorphine, for example, versus actually inducting and maintaining patients within the primary care practice. Finally, we must address the external context. Many initiatives and requirements occur across the board, and we have too much on our plates. Best intentions may not be enough. An external context also matters to the patients themselves, as somebody earlier asked the question about social determinants of health. Many patients have very complex needs that go beyond healthcare. Without addressing housing, for instance, it may be quite difficult to address the mental health and substance use need itself. But social services, housing, and other systems are frequently engaged in the specialty sector, but less so in primary care. All that said, delivery systems can be significant drivers of innovations, such as integrated care, if the resources, knowledge providers, and external context are all considered and engaged, along with payment systems and need for sustainability. Thank you for your time.
Thank you very much, Sharon. That was great. Next up is Kirsten Baronio, and take it away, Kirsten.
Thanks, Richard, and thank you to this forum and the National Academies for inviting me to participate in this webinar today. I found the presentations in the prior webinars and earlier today in this session really very interesting. I'm going to focus on two components of the integration models that we've been discussing that are widely considered to be critical, but are often difficult to finance. So specifically, consultation with a behavioral health specialist, as well as the case management, care coordination activities. I'm going to talk about some of the issues that impede broader implementation, in my opinion, as well as some opportunities that I think may help going forward with improving and availability of these kinds of models. So next slide, please. So with regard to Medicare, I would be remiss if I didn't mention these behavioral health integration codes that were recently implemented and available for billing through the Medicare program starting in 2017. They were designed to basically support provision of the collaborative care model. As you probably know, Medicare generally is very influential in terms of other programs, including Medicaid as well as private insurance. So always important to, get Medicare on your side. But unfortunately, what we found is that claiming for these particular codes that were established has been very low. Part of the issue apparently is, or is thought to be, that there are a number of processes and structures that have to be in place already in order to bill for these services. And these kinds of implementation costs are not, are rarely covered, and is an issue that I think is going to, weave throughout my presentation today. Another possible issue with regard to how these codes were set up is that payment for the behavioral health specialist has to flow through the primary care provider. So this creates some administrative burden for the primary care provider and a disincentive, frankly, for the behavioral health specialist. So those are the challenges. I did want to point out an opportunity that I think exists in a more recent development in Medicare, which is establishment of codes to pay for what are broadly referred to as interprofessional consults. And these are not tied necessarily to behavioral health care even, but would allow for at least coverage, in my opinion, of the consultation part of these models. And I think maybe a more flexible way to go. So I wanted to flag that for your attention. The other area, big area of development recently that I think is helpful in terms of what Medicare covers and can support with regard to integration is the recent expansion, particularly during the COVID-19 pandemic, of coverage for telehealth services. As you may know, Medicare, the CMS has recently proposed to extend coverage of some of this, of some of the telehealth services they have allowed to be covered during the pandemic. Some, but not all. I did want to note one in particular area, which was actually authorized in the Support Act, a recent piece of legislation enacted by Congress, or enacted and signed by the president, to be enacted, that really tried to use the Medicare and Medicaid programs as levers to address some of the opioid crisis issues that we're dealing with. In any case, that law actually changed a limitation in Medicare that broadly applies to limit telehealth to only certain geographic areas and to limit the ability to use for a person to access telehealth from their home. That was changed for substance abuse services as well as co-occurring mental health conditions. So this recent rule implements that new provision, and I wanted to be sure you all were aware of that. Some of the shortcomings, however, in that rule are that it does not go as far as we had hoped, frankly, in terms of allowing for continued coverage of services provided only by telephone. And there are a number of other key expansions that are not proposed to be continued. Some of that, again, is due to this, the fact that for things like this geographic limitation in Medicare that exists in statute, Congress would actually have to act to change that. And make that more flexible. Another big opportunity that I see in Medicare is this new opioid treatment program benefit, the new coverage of methadone clinics for Medicare beneficiaries. This same payment rule includes important updates for that new benefit. The benefit just became available in January, so it's very new. But I think it's important to think about this new benefit in relation to integration, because as we've seen in the Medicaid program, and in particular in places like Vermont, where they implemented what's referred to as the hub and spoke model to addressing opioid use disorder. The hubs are actually opioid treatment programs, and they really have been able to provide valuable support to the more mainstream office-based providers to help expand the capacity to provide opioid use disorder treatment. So hopefully this new bundled payment with the flexibilities that come with a more bundled payment will help broaden availability of opioid treatment programs for Medicare beneficiaries and hopefully beyond in Medicaid and private insurance. Another new development really in this new physician fee schedule rule that I referred to earlier is this new payment in Medicare that they are finalizing for medication-assisted treatment in emergency departments, which, although, again, it's not a collaborative care model exactly, it does try to get at the idea of trying to integrate specialty care into more mainstream settings. And there has been some evidence of that this can be helpful in terms of engaging people right in the emergency department, getting them medication, getting them connected to care. So I think another important development. Next slide, please. Now I'm going to switch to Medicaid. I think with regard to Medicaid, it's important to note that there is a challenge that exists in the general Medicaid rules, policies really, that Medicaid generally does not allow for reimbursement of consultations where the beneficiary is not present for the service. So that's created quite an obstacle to paying for consultation types of services with specialists. CMS has clarified that the cost of that consultation can be incorporated into the payment for a primary care encounter. However, however, the rates for those encounters, as many of you know, tend to be quite low already. So the idea of trying to incorporate more into that rate is not really likely to result in much change and much broadening of availability. I did want to note this clarification was included in a state Medicaid director letter issued in November of 2018. If you want more details on that policy, that letter addresses opportunities to design innovative service delivery systems for adults with SMI and children with serious emotional disturbance. And in that letter, I also wanted to point out there's a chart at the towards the back that kind of tries to map different components of the collaborative care model to specific Medicaid benefits. For example, one of the benefits is case management, targeted case management and health hums that I'll talk about in a minute. But before I do that, I wanted to talk about opportunities that I see available through Section 1115 authority, and specifically a demonstration that was recently approved for Rhode Island as part of their broader Section 1115 demonstration. Section 1115 refers to some discretionary authority that CMS has in the Social Security Act that allows CMS to waive certain rules that would ordinarily apply as long as what the state is proposing to do in their demonstration does further the purposes of the Medicaid program. But in this particular part of Rhode Island's broader demonstration, they have received approval to continue and expand upon an existing program they had implemented with a grant from the Center for Medicare and Medicaid Innovation, a SIM grant, if you all are familiar with that term, State Innovation Model. That particular grant that they had allowed them to implement something similar to the Massachusetts Child Psychiatry Access Project, whereby a team of behavioral health specialists and care managers can really help to support multiple pediatricians and improve access to behavioral health care. Rhode Island had found this very helpful. They were able to actually pay those specialists directly instead of having to run the payment through the payment for the primary care physician. And they found that very useful and wanted to continue that and to expand it to adults as well. And they have been approved to do so through the Section 1115 demonstration. And I will say that it was helpful that Medicare had already approved this kind of approach through their interprofessional consult codes that they had already put in place. So again, the interplay between Medicare and Medicaid has been essential, I think, in that regard. I also wanted to point out HRSA has a grant program where they are supporting some more of this kind of approach where there's a team of behavioral health specialists who can support pediatricians in providing access to behavioral health care called the Pediatric Mental Health Care Access Program. And I think that's another important theme I wanted to highlight, is just that the importance of tying together more flexible federal funding through these kinds of grants that can help cover some of the upfront implementation costs with more of the coverage benefits that are available through programs like Medicare and Medicaid. And on to a couple more of those benefits. Case management in Medicaid is an important benefit for covering some key components, as well as care coordination. And the health home benefit in Medicaid is another important benefit. I've mentioned some of these issues, and I think all of our prior presenters have touched upon workforce challenges. So I will leave further discussion of these till the Q&A.
Thanks, Kirsten. And our wrap-up, our last speaker will be David Smith from Third Horizon Strategies. David?
Great, thank you. This is not an example of saving the best for last. Regrettably, been some amazing speakers, and Kirsten, I probably should have just yielded my 7 minutes over to you so you could continue showing the really unique insight, but not a call I'll make. I'll just quickly introduce myself as the founder and CEO of a little firm called Third Horizon Strategies, but also the progenitor of an alliance called the Alliance for Addiction Payment Reform, which is a vestige of a previous professional life, having spent a number of years with Governor Mike Leavitt at his firm Leavitt Partners following his tenure at Health and Human Services. And one of the primary things we labored doing in our work was focusing on the economics of the system and the way in which money moves from taxpayers or employers or consumers to payers, to managers, to provider groups, doctors, and then ultimately impacts patient care. And the highly fragmented way in which those monies move through the system and automatically create disincentives to typically do the types of things that science argues we ought to do to promote better health outcomes. I came to the SUD work, which is where I'll primarily organize my thoughts today, partly by the professional backdrop I just gave you, but also through some lived experience. About 20 years ago, I lost my father. A couple of years after that, I lost my little brother. And a couple of years after that, lost my little sister, all to opioid overdoses, and watched their journeys in and out of recovery, in and out of rehab, in and out of group settings, as they were discharged and were kind of declared cured of addiction, and would go back to the social stressors and the environments that were correlated with the onset of the SUD in the first place. And with stunning realization, came to find out they were not in fact cured, but that there was a disruption in their recovery and ultimately led to their fatal events. And that really, those early experiences have stuck with me in profound ways, particularly as I was doing this work with Governor Leavitt. And this kind of led to a body of work, which I'll spend just a couple brief minutes telling you about. If we could go to the next slide. About 3 years ago, a colleague of mine and a friend who was the co-founder of a grassroots advocacy group called Facing Addiction, and I kind of formed a bit of a collaborative. And the basis of the collaborative was to say, okay, if culturally we have moved to a place where we generally tend to see addiction less as a moral failing, but more of a disease, and if we're slowly making the cultural pivot to seeing it not just as a disease, but as a chronic disease, and we know the delivery system is not giving us what we're paying for in treatment and recovery, short or long term, are there ways through which we can reconfigure the dollar at the payer level, whether it's a government entity as a payer or a commercial actor as a payer, to better organize the delivery system to do all of the things that have really been spoken about today? And we set a table in Washington and invited a bunch of payers and health systems and experts, and had this discussion with about 30 folks. And the consensus was, well, yes, there is a moment. Nobody really knows what this looks like. This is not something done widely in behavioral health or mental health. services, but we believe there ought to be a way to reorganize the dollar to align incentives. And so we created over about an 8-month period, we organized into work groups, and we created something called the Addiction Recovery Medical Home Alternative Payment Model, which in the beginning was really just designed to be more of a thought exercise and a contribution to the field, and a little less an application. And we found ourselves, after the publication of this first paper, getting phone calls from health plans, state governments, and others saying, oh my gosh, this actually resonates a lot, and there's no way we can really do worse than we're doing today. So can you help us take a crack at this? And so we organized or perpetuated this alliance, and this alliance has continued to support efforts with the plurality of stakeholders, governments, payers, and or provider entities in a bunch of different states, which you see at the bottom. Most prominently, and the one we're probably most enthusiastic about, is a contract with the Washington Healthcare Authority and helping them respond to a CMS grant that would memorialize this type of APM statewide with their MCO partners over time. And several of these have moved along really well, and there's a couple of press releases of exciting things coming out on a couple in particular in the coming weeks. Since I don't have time to walk you through the exhaustive elements of the model, what I thought I'd do is just walk through the quick principles of the model and then just give you quick context. So Richard, keep me honest on time. I'm going to try to go through this quickly. Let's go to the next slide. We wanted to build the model with a bunch of different partners. And these were all the different entities and organizations that have participated or are actively participating in the construction of this. And the principles that this group came to coalesce around, let's go to the next slide, are the following 10 principles. The first is we wanted to create a model that was flexible in recognizing that individuals come to recovery from a bunch of different places. It could be through the prison system, a primary care physician, an emergency department, and that if anything, we have too many wrong doors in how people access treatment, and we need to turn as many wrong doors into the right door as possible so the system can be adaptive and flexible in meeting patients where they are. Number two, we came to feel that there were 3 really critical components, both for terms of economics and in terms of how we organize the care model, to be structured around sequential phases. The first being a pre-recovery stabilization period that is post-traumatic or perhaps post-event period, or just the realization of an individual or the encouragement of a family member to enter treatment. A longer phase, which is the recovery initiation and active treatment, which really explores or tries to get that patient in an extended period of remission from the SUD and puts space in their recovery journey. And the third is perhaps the most important, the longer term part of the recovery journey, which is community-based recovery management. When a patient, quote unquote, goes home, goes back to work, goes back to their marriage, any of the other things that may have been correlative with the onset of the SUD or could trigger a recovery disruption, we wanted to make sure the care model was flexible around that. Number 3, this has been said exhaustively, I don't need to say it much, we wanted to make sure that the economics of the model would support the multidisciplinary evidence-based needs that a patient has. That's everything from primary care integration, integrating specialists in the events of comorbidities or other co-occurring mental illness, and so the recovery team and the expectations we've built around this care team are wide in that regard. Number 4, wanted to ensure that there was a broad continuum of care. We generally pegged ourselves to the ASAM continuum and require an integrated treatment recovery network that was capable of facilitating inpatient, outpatient, technology-based, peer-based types of supports in a community or in a clinical or recovery setting accretive to the patient. 5, that everybody on that continuum was in point of fact integrated, and the ability to share clinical information in HIPAA compliant ways and 42 CFR compliant ways was adhered to, but that there were elements and instruments that would allow for the kind of technology and record integration capacity management, and referral management that would be so critical to supporting a patient along that continuum in their care journey. Next slide, number 6. The inclusion of comorbidities and co-occurring mental health conditions. This has changed a little bit from market to market and payer to payer, but the recognition that SUD does not live in a vacuum, and even if it is a primary diagnosis, there are in many other cases other social, mental, or physical factors that may impede or be supportive of the patient's journey. Number 7, that this is patient-centered. This is one that has been a little controversial. I have come to believe through my own lived experience that patients ought to be every bit as involved in their recovery journey as a medical professional. Patients who are in recovery tend to have a sense of what their triggers are, what all of the other elements are that exist in their ecosystem that may improve, accelerate, or impede recovery, and that patient inclusion in that process is critical. Number 8 is the punchline. Yes, sir.
Could you wrap it up in about a minute and a half?
I will.
Thanks.
90 seconds, I can do that, Richard, thank you. Number 8 is the punchline, which is aligning incentives. And we have started this by using a either retrospective or prospective bundled payment approach and setting case rates along the different phases of the recovery journey. So a provider who's able to organize itself along the principles I've shared here can take a risk-based payment and can expend those resources in a way that truly are patient-centered. Longitudinal, this is a little tricky because of our annual underwriting cycle, but the idea is to try to have this model live and stay with the patient for as long as the supporting payer stays with the patient through that underwriting cycle with a target of 5 years. And lastly, a dynamic treatment and recovery plan, technology-based and supported, and covers the full range of biopsychosocial considerations for a patient. Next slide, Richard, I'm not going to go into it. I'll just show this as reference. 5 key areas we covered in the model. Happy to talk through these in the Q&A, but a couple of these I hit in the principles. Next slide. And then one more slide. And then the general outline for how we define these phases, how we consider the static or declining bundle payments, and any of the payments that are contingent on quality and might yield a bonus. The model looks very different in the different markets we're working through, but has generally adhered to the principles I've shared and the general APM architecture we promulgated in the beginning. So, Richard, sorry for going a bit over, but I will pause there.
Terrific. Thank you so much. So I'd like to start the discussion period by sort of throwing out a few questions that hopefully most of the panel will want to weigh in on. The first one asks you to sort of take the world as it is and think about the existing business case, sort of as outlined by Bob at the beginning, some of the payment issues that Kirsten and Bob and others have talked about, and the regulations that Sharon alluded to. And what I heard is all of you sort of focus a bit on flexibility and finding those elements of the model that are most essential to work into, figure out how to organize so that they work under existing payment and business arrangements. So what would you do? What are the key things that you got to do? And in a sense, this is we've heard about the models and we've heard about the, wonderful things that a few places have been accomplished. What do we need to do to Walmartize all of this? And that's addressed to all of you. So when we go in order.
I can start. I think being flexible about the model is really critical, as I tried to point out in my remarks. And something that someone, I think Frank Degree said at an earlier webinar around really not making it disease specific, I thought was a really interesting point, that, consultations and care management, case management are needed for multiple conditions. And if you could think about these kinds of services and the team-based approach more broadly for your whole patient population, or at least the subset that has a very serious chronic condition, then that might make it more feasible to think about how to finance some of those services going forward. For example, this interprofessional consult code is not tied to behavioral health. It can be applied to other kinds like diabetes management or cardiologist consult, et cetera. So I think telehealth is critical for some of this, particularly in rural areas. We need to continue broad coverage of telehealth to enable access to those specialists. And we need to be more flexible. At least I know in the Medicaid program, I didn't get to this, but it's pretty restrictive how case management can be claimed. There's 4 different components that have to be provided. So I think we can think about how we can be more flexible in some of those policies, frankly. And then just implementation costs. We need to provide resources to implement all of these changes, and training, et cetera. So I'll leave it at that.
Bob, you
I think I think Kirsten's point in calling on frank degree is important. We do see people with depression or mixed depression and anxiety, but in primary care, we tend to deal with the whole person. So you're often dealing not just with their mental health issues, but with an array of other chronic or acute health conditions. And you're really trying to balance the needs of each of those and maximize the therapeutic value, not only of that visit, but of the relationship over time. I think if you want to know about existing payment models, I was a huge fan of the Vermont Blueprint for Health, which happened under a Medicare waiver, but it created community resources for behavioral health, social services, and others that small practices who couldn't otherwise afford those kinds of functions could all draw on the same set of resources in the community and forge relationships with those folks because they were local. Or if you look at the payment models and other support systems for FQHCs, we have a paper coming out soon that demonstrates FQHCs have the richest mix of patient-centered medical home components, and it's no surprise because of what we heard in the first panel, the degree of facilitation and support for those coming into practices. So I think we have existing models. They're just not, they haven't been translated for primary care writ large, and I think that's the next opportunity.
Sharon?
Sure. I would also emphasize, I agree with the other things that have been said, but I would also emphasize the need for collaboration across systems and across expertise and across payers as well. Kirsten mentioned the Vermont hub and spoke model. I've been working with Washington and their hub and spoke model, which is actually organized fairly differently because it's about this is about opioid use disorder, about having the expert as the hub, and in their original 6 networks, primary care was the expert for 3 of those. But then those networks include substance use, include mental disorder. It's organized in part by the state substance use system, which is contributing the funding for the nurse care managers and for some of the infrastructure that I was talking about. And because for opioid use disorder, Medicaid is a huge player. Most people in Washington state with OUD are under Medicaid. They're able to engage with the Medicaid decision makers in the state to try to change some of those regulatory things. So I guess I'm saying I'm stepping a little bit beyond the as it is right now, but that with the right people engaged, you can use some of the systems right now to try to make it better than. I also want to emphasize what Parinda said earlier in Cherokee about you treat this as business as usual. And I think one of the problems that we keep getting tripped up on is that we're treating mental health and substance use disorders as different, as it happens to somebody else, as somebody else will take care of it. And that's part of where all of our challenges are here, is that the systems need to say, and we need to say, that's not enough, that's not okay. So thank you.
David?
Yeah, I'll pick up on the last term you used a minute ago, Richard, the term Walmartized, which would be the ideal, right? Just to be able to scale all of the evidence-based thinking that has gone into the field over the last couple of years. There's unfortunately a couple fallacies with the premise. One is that although we've watched Walmart scale domestically very well, we also know anytime Walmart has gone into another country, that is another set of regulatory or cultural conditions, that same scaling formula doesn't work quite as well. And it pays homage to the unique cultural idiosyncrasies for us from community to community. The second is taking the world as it is. And the world as it is doesn't really leave for much of a scaling opportunity for some of these challenges. So we very much taken your admonition and the work we've done and taken the world as it is. And we know a couple things about that world. Number one, we know there's more than enough money, technology, science, clinical know-how, evidence to solve our way out of a lot of these challenges throughout behavioral health. Like, we know many of the answers. We get in our own way economically and sociologically and politically, and being able to institute those changes and those opportunities. The second thing we know is that people do hard things when they're in pain. And pain in our industry tends to be economic. At least for many of the stakeholders that move our $4 trillion around. Our approach has been to try to quantify that pain for providers and payers, identify a more ideal way to organize the dollar and delivery assets to alleviate that pain, and then create consensus at the community level that it acknowledges the idiosyncrasies of those communities, and of the systemic stakeholders that sit in those communities to try to advance the work.
Great, thanks for that. And it's a perfect lead into my next question. But before I ask it, I want to encourage everybody who's listening to submit questions in the Q&A box. Otherwise, you will have to listen to myself and possibly Colleen ask all the great questions we've been thinking of for the last 20 years. So please do ask it in the Q&A section. So let me jump off of David's remarks, because I think they were just right in terms of saying, let's think about how the world gets changed in order to scale and to make these things happen. And it seems to me one lesson that Bob gave us right off the bat is that a focus on codes and fee-for-service may not be just the right direction at all, and that perhaps we out of the mental health community and the addiction treatment communities ought to be more focused on alternative payment systems than they typically have been. And so I'd like to get each of the panelists to talk a little bit about which ones they view as most promising and why, because lots of people have put a lot of money down on ACOs and they haven't really done that much on the behavioral health front, but there are, I'm sure, other models. So I'd like to hear from each of you. So maybe we ought to, why don't we start with Bob? You're on mute.
Sorry about that. Primary care, as I said at the beginning, is where half of all care happens, and sometimes only happens. But if you look at Medicare, it's only 2.2 to 4% of total spend. And if you look across MEPS, it's only about 7% of total spend for all payers. Alternative payment models that stick to that kind of low financing of the primary care function is not going to create space for the rest of mental health behavioral health, oral health to come into primary care in an integrated way. And I just don't think there's any way to get around it. But you have to put more resources in and put them in a way that support the integration and those other professionals to be embedded in the same space. To David's point, I think the money's there. And I don't think it takes a huge amount of it, as Rhode Island and Oregon and Delaware are showing us. So I think an alternative payment model is going to have to enable that. And I think CPC Plus may be one of the better ones. Primary Care First may do that as well, because it gives an upfront increase in a capitated format that I think gives the flexibility needed to bring those folks in.
Sharon, why don't you take a crack?
I was thinking about what David was just talking about with the long-term view. And when we talk about things like bundled payments and those kinds of approaches, it's really hard to do that with the long-term view, which is what we want to do if we're talking about recovery, if we're talking about a chronic care model. So I don't have an answer to what's my favorite alternative payment model, but there are a lot of challenges with it that we need to think that are system-wide as well in terms of making this better. It can't just be fee-for-service. It can't, because fee-for-service is your acute care model, and we need to be focused on the chronic care model and thinking about how to engage that. I also want to say that there's always talk about value-based payments and incentives and associating payments with quality. And I think that is conceptually a very good idea. And I think it's harder to do in practice for some of the reasons that I talked about in my introduction, where who's going to make that incentive, and is the receiver of that incentive only obligated to that payer system? Are we going to do something that's across systems so it actually changes how we're paying attention? Are the incentives big enough to make people do something different?
David, do you want to take a crack?
Yeah, I live by the edict that there's a universal human maxim that you get what you pay for. And we have gotten thus far what we have paid for out of the system in the way we've structured coding and fee for service and the like. I would agree with Robert's point that CPC Plus, I think the next generation ACO model, and some of the permutations of the BPCI advanced models were appealing and attractive, and have demonstrated good results. But Richard, to your point, we haven't seen them at scale, and we haven't seen them work in ways that really lift the burden. And I take a bit of a dour view on this, to be candid. We have not pushed ourselves hard enough to make that successful. Now, if you push too hard, you run a risk of risk exposure and leaving patients without care and solvency issues. And we've seen this song and dance in our history before. But if you allow people to kind of voluntarily come along while balance sheets are filling up on the coffers of fee-for-service, and we don't challenge ourselves to reorganize the system in a way that is more integrated, more inclusive, better coordinating, and more patient-centric, we're going to continue what we've gotten. I lament, like many of you, I've not been to a conference in months, and it's actually been kind of a little bit of a blessing. This conference notwithstanding, I'd love to be with all of you in person, but conference after conference, you see people, CEOs stand up and they talk about the incredible things they're doing in value-based care and all of the wonderful relationships and collaboratives that they're a part of. And then you unwind their P&L, and it represents 5% of their total income. 5% is not enough to move an institution to reorganize itself in the right way. We need to push ourselves harder and faster. Mental health, behavioral health has to have a seat at that table, and being part of that value chain, or we will still leave a major efficiency gap in patients' whole health.
That's a great challenge for us. Kirsten, you want to take a shot at this one?
Sure. I don't have a particular model to call out, but some issues that I think are important, that would be important to include in any sort of alternative payment approach, would be to make sure that it's multi-payer. I mean, the administrative burden that providers face that I hear about all the time with having to manage all these different funding streams and different requirements is really a big factor that needs to be addressed somehow. And if there was a way to include that in a model, I think that would be a big win. I also think, if we're talking about trying to, presumably this model is aimed at improving integration. We don't have great measures for that. I don't know what we have really on that point. So I don't really see how we, if the alternative payment model would presumably be tying payments to some sort of process change or outcomes. I don't think we're quite there yet. And then the rates need to be, there's a big issue with reimbursement rates not being adequate. I know, it's easy to sort of write that off as, well, paid providers always want to be paid more. But I mean, when you look at kind of what happened, for example, in Virginia, where when Virginia implemented their 1115 demonstration to improve access to substance use disorder treatment, they greatly increased their reimbursement rates, and magically, lots more providers participated in Medicaid. There's just more and more examples of that, and of that how you can push the ball forward if you really want to. I also wanted to just make people aware, trying to get at this issue of what do we do about the rates. The Medicaid program is currently overseeing a demonstration program, again authorized by the Support Act, to look at, to fund states to take a look at their rates. I think there are about 15 states with planning grants, as I recall, where they're getting the money to really look at what is the problem with the lack of participation in our Medicaid program. How do our rates compare? Where are our providers throughout our state? State Medicaid programs, state agencies right now in particular are really strapped. They don't have extra money lying around to do that kind of analysis. So this gives them a little bit of funding and an incentive to really look at this. And one of the issues that they're supposed to look at in terms of assessing participation in Medicaid is what do the rates look like. So, given the issues around all of those three factors, I don't know. I couldn't tell you what an ideal alternative payment system should look like right now. But maybe someone else can.
Yeah, I wasn't looking for ideal. I was looking for okay. But let me and I think your point, although a bit understated, is important to remind everybody, which is that states are financially in deep yogurt right now. And it's only going to get worse for the next year or two. Let me now switch to something that all of you have sort of kind of alluded to, which is typically when we think about new programs or new innovations, we usually think about using both pull and push incentives. And so far, the entire discussion we've been having and the entire discussion in the field has been largely about pull incentives, like paying more, paying different. And Kirsten referred to sort of some of the push, and so did David a bit. And it was part of Sharon's. Sharon had half a slide on it. And I think what I'd like to hear about is, one, what specifically should we be pushing on in terms of what money should we be paying for up front to get people to do more? And then whose responsibility is it to do it? I'll take volunteers to see who goes first.
I'm happy to jump in for a second and give my colleagues time to think of an even better answer. I want to go back to something you said a second ago, Richard, about states being in deep yogurt. The budget climate, obviously, for the next couple of years is profoundly important, and I think creates a really important opening for all of this dialogue and for this field to maybe begin to break into state governors' offices and legislative houses in a bit of a different way. We have a tremendous amount of evidence and science that shows how the nature of certain interventions, how a certain combination of people, process, and technology can shift and change health outcomes and lower the economic burden on states. States are going to be looking for demonstrable, scorable savings a lot over the next few years. There's a huge opportunity to prosecute a case for behavioral health. I think whether or not behavioral health advocates prosecute that case or not, states are going to have to take critical action. And I think you're going to see states raise the bar for MCOs who administer Medicaid or for MA plans who do this for the federal government. And absent a way to concentrate that financial energy to the right places and the right ways, the right parts of the infrastructure, will continue to exacerbate the efficiency gap. So the more direct answer, Richard, we have an incredible FQHC infrastructure in this country. And we have left them on the sidelines for years. We have an amazing mental health capacity in certain parts of this country, other parts we've underinvested in. And we have safety net hospitals who don't get up every day thinking about their next blockbuster transaction to create an efficiency for Epic. They're getting up every day and thinking about the service that they do for their community. So in the context of the parts of our country who tend to get the least of the $4 trillion we have and suffer a greater disproportionate burden under the stress of mental health and addiction, it's focusing on those parts of the infrastructure, on those communities, and the locus of primary care, I think, as a means to help facilitate improved linkages for patients to all other parts of the system that can be accretive to their whole health.
Anybody else?
I'll pick up, again, this is not exactly answering your question, but somebody earlier said no wrong door. And I think that we've got this idea that people are showing up at their primary care docs, and then the primary care doc should engage with their mental health and their substance use issues also. But we need to help drive the pathways to these systems, to these integrated care or holistic. Maybe it's not always integrated care, but maybe it's got collaborations. Maybe it's got the pieces in place and the people. Kirsten, thank you for pointing out the payment rates, because it's not just payment for primary care providers, it's also payment for the specialty sector, which is quite low as well. So I think that the making this less siloed, I guess that's really that we really need to be able to encourage people to seek care and get access to the right systems in the right places. And maybe that needs, the reason that I was taking a system perspective in my speaking is that this isn't just about my primary care practice is enlightened, right? This has to be coming at some level from top down, that these people are in your practices. We are engaging with them. It matters to the insurers because it matters for all those other conditions that people are showing up with. I mean, there's so many layers played in here. Who's the pusher? In this case, I'm not quite certain of what the driver is to make those things happen, other than us keep hammering at it from all of our perspectives.
Yeah, and I would add that I agree with what everyone said, but I think it is important to recognize that, and I think payers are increasingly recognizing. I know when I was at CMS, state Medicaid programs were increasingly focused on this population of people with behavioral health conditions. And why was that? Because they were starting to recognize they are driving their costs. Like we've seen repeatedly that it's this sort of small segment, particularly the very seriously mentally ill, but even those with chronic, less serious illnesses are driving costs, and they're driving the medical costs, not because if you look at overall spending on behavioral health, it's very low as a percentage, but if you look at the medical spending for this population, it's disproportionate. So I think payers are really key to starting to recognize this dynamic and really driving their providers and their networks to screen. We know that primary care providers don't screen for depression and alcohol, even though they're so highly prevalent in their overall. As a general finding, we see that again and again. Making sure that there's screening, facilitating access to treatment for those conditions. One reason they may not screen is they just don't know what to do if they see that in their patient population. Making it easy for them to access a behavioral health specialist. Making it, giving them time to get training through Project Echo to better be able to deal with some of that in their own population, as well as have the connections to specialists. These things cost money, time is money. So, it's important to recognize that. I think policymakers often just think, oh, well, if we cover something, then it will just get done. But that's not the whole picture. We need to recognize the cost, the time that needs to go into making these kinds of changes, but also recognize that those are necessary, because if you don't address these issues, they will come back, and they do come back and bite you.
Bob, do you want to say anything? You're on mute. You're still on
Sorry
mute.
about that. We screen all of our patients for depression. Our MAs are trained to use the PHQ-2 and then flow into the PHQ-9 if they hit someone who has an issue. And while I can do pharmacotherapy, I can do initial counseling and even some initial CBT counseling. Until Virginia put money into the Virginia Mental Health Access Program, my next step, if I wanted to get them into counseling of whatever variety, was to pull out an Excel spreadsheet and give them at least 5 people who took their insurance and offered that therapeutic modality, because it was likely out of date. And my hope was at least one of those 5 might actually be able to take them. And I only had that spreadsheet because there's a psychiatrist in our area who developed that spreadsheet for us to use. It's very cumbersome. But VMAP, putting $1.5 million on the table to create a program where I could just call and have someone, a care coordinator, take over the process of getting them into that service was incredibly helpful. It makes other practices reluctant to screen if they don't have a way of dealing with it. We've shown this for a variety of conditions. And so if we can create that kind of shared resource for managing that person's getting into next stages of care, I think it would make screening and treatment much better.
Great. That's really, were great answers. Thank you. Colleen, do you want to sort of start to curate the stuff from the listeners?
Yep. Great. Thank you, Richard. So the first question is actually connecting this session to our prior session. The participant asks in particular about the nurse-led community health center model that we heard about, and says, okay, that integration model was scalable. Is there something that we can learn from programs like that one that seem to have come to scale, at least at the state level, and have been sustained over time?
What I do like about that model is that it really captures many of the things that we've been talking about, right? You've got, you have training and technical assistance. You have flexibility to give that knowledge, that support, the referral sources, any of those kinds of things to the person who you're training. So you've got different levels of people who are engaged now. It's not just the nurses, but it's other kinds of people. They need different information. They need different kinds of supports. I also think that they've worked with the state to get some of the reimbursement issues taken care of and addressing some of that. So to me, the beauty of that model, and having sustained it since 2003, and everybody talks about it. Everybody wants to be that model, wants to use it. Washington, that I talked about, is incorporating some of it, but that it is continually looking at what's going on in the world and saying, now we need to do this. Now we need to do this. And presumably, I don't know this, but presumably there's an infrastructure of the people who are helping this model do those things and making those engagements with the state, with other people. So it's not just on individual systems, individual practitioners. So that's what I would say. I think it's a great example of how things can work.
Other comments on this one? If not, I can jump to the next one.
I would just say I'd welcome it in my community. I would welcome it as a resource. Please bring it to us.
So, so the next question comes actually from the Q&A from the last session, but I hold it over for this one because it really relates to financing around sustainability, and it relates to the business case. So the question was, do we have a business case for care integration in the primary care sector? Do we have a business case specifically for payers and for provider organizations? And if not, how can we get there?
Well, I presented the one study from Intermountain Health that showed there was overall savings, and there are many others like that. So that's been one of my longstanding frustrations. There is a business case for this. I don't know if it's a struggle to figure out a payment modality that will bring it into more common usage, or if it's someone else's problem. I don't know the barriers. If anyone else has ideas about that, I would welcome it.
Yeah, this is David. I think this is a bit of a three-step process in being able to build a business case. I think step one is you've got to have the evidence that an intervention is demonstrably improving health outcomes and while simultaneously using less resources than it is producing improved health outcomes. So the evidence exists. And by the way, we have checked that box in spades in this industry. I mean, every month, journal after journal, evidence-based peer-reviewed publication after publication demonstrates we've done that hard work. But step two in that arc is to be able to say, okay, how does this actually fit in and compare financially? How do we quantify the dollar value and for whom? And I think the two actors that matter, and there's a bunch of different ways you can cut this, but one actor is the payer, whether it's an MCO or the state or the federal government. And the easiest quantifiable unit of interest for them is, did it save me money over time? Like that's the most base thing that they're going to be interested in. Governments may be set aside. For a hospital system, they might ask the question, would this intervention either be a revenue line that would drive, or a service line that would drive additional revenue, or would it decrease the cost I'm bearing because of low reimbursement for a certain type of utilization? So if you juxtapose it through that second step and you say, where is the value capturing for whom? Who is this solving a bigger problem for? The third and final step is to be able to really quantify how you redirect that value. Who is the biggest beneficiary of the value? And then how do you have to reorganize or reconstitute a payment structure to either shift accountability or shift the rewards for what's occurred? But being able to take that second step, take the evidence, combine it with the financial information on the system, measure it against the cohort and say, this is definitively what we believe this evidence shows can be captured in this context. The rest of it, and I don't mean to sound pejorative or simplistic, the rest of it is mechanical. But it's that second step we're not very great at. And I don't think that's a fault to the research community. I think it's generally been a fault to the healthcare industrial complex that has not met the research community in the right way. I think that's shifting. And I think that the COVID dynamic, painful as it is going to put enough pressure on federal budgets, state budgets, and provider balance sheets. It's going to force a very different conversation. And again, I think this is a really interesting time to link step one to step two, better quantify where those savings and value capture opportunities exist, and then use the mechanical features we know from the last 10 to 20 years can work to operationalize them.
So the next question relates to, basically the point is made that the incentives are not strong enough to change provider behavior, and the comment is written specifically in the context of providers in community mental health centers, but I think it could go beyond that. In the context of the point you just made, David, about financial pressures, I think it would be helpful to talk a little bit more about non-financial incentives as well as financial incentives that can be used to push integration more strongly, to really get providers to be incentivized to change behavior. And Sharon, you alluded to this, but you didn't talk in detail about what the non-financial incentives are that we should be thinking about.
I should
Kirsten,
have an
I
answer
thought
on
she
the
was
tip of my
calling
tongue.
on me, so I'm happy to defer to you guys.
I mean, non-financial incentives could be, I mean, even things like providing technical assistance. It could be other structural things. It could be offering, maybe it's not a direct financial incentive, but placing a care manager in a system. Some of those kinds of things can play in as non-financial incentives. How else can we support what's going on? I should have a better answer to that, but I don't have one on the tip of my tongue, so I apologize. Yeah.
Yeah, I think I saw a recent article on that topic of just how having a behavioral health care manager can really help alleviate some of the pressures on primary care providers to just because they are dealing with so much so often, that can be helpful. I mean, I think non-financial incentives, it's I think sometimes providers may want to avoid this population because they don't know that there's improvement that will be quickly seen. I think that reinforcing ability to see that people improve. I've heard about how reticence to, for example, prescribe buprenorphine has been somewhat overcome because you can see an improvement in that population. That's another kind of non-financial incentive. I think that's important to recognize and just raise awareness about. But in terms of financial incentives and payers, I mean, I think it's really important to look at the overall costs for the patients, as I was pointing out, the medical costs. That can be, it's harder to make those direct connections, but that they are real, and we need to do a better job of measuring that.
Sharon, do you want to jump back in here?
Yeah, thank you. I just needed a moment to get my head around it. But another kind of thing people talk about with non-financial incentives are things like reward systems. You get the 3 stars that you put next to your name in the directory, or you get a certificate that shows that you've engaged in that you think about mental health and substance use disorders. And those can be used to drive people to you and to see you as a practice that they want to be in and engage with. So that's all I want to add. Thank you.
That's great. Kirsten, this is a very specific question. I think I'll try to direct it toward you. Can you comment on whether you see the new CMS-CMMI demonstration model chart, community healthcare and rural transformation, as an opportunity to include behavioral health integration to reimburse or better reimburse primary care providers for the services that they're providing?
Sure. I don't know a lot about this model, but in general, CMMI, what their programs models often do is provide some upfront funding for some of those implementation costs, those costs of looking at what are the barriers to better access to care in my community. How can I make these connections between, for example, behavioral health and other kinds of settings, whether they be SNFs or whatever. I think there's some mention of nursing homes in that model. But I think they do try to address some of that in their with their upfront funding. However, they do often there's this often this limitation in federal grants, which is that it's only a limited, or it cannot be used at all for what are called administrative costs, and that can really limit the degree to which those kinds of grants can be helpful to address what I'm talking about. So I did want to flag that. Another theme with CMMI grants is they do tend to focus quite a bit on care coordination. It's a running theme. So it comes up a lot. It's really central to what we're talking about here. So I would expect that would present opportunities to, really try to move the ball forward in those communities that get those funds to address these issues. But, then what happens? Like, what happens after the funding's gone? And how do you spread that to other communities even within that state? That does require the system-wide approach that I think Sharon was trying to point out, and I think it's really important. And some of the things I was talking about get so in the weeds and are things that very few people know about, and I think that's important to recognize and to really try to look. I think personally at the state level that there needs to be some entity at the state level that will draw together all of these resources and provide supports for people like Dr. Phillips to really help improve access and really help them understand how they can bill for those kinds of services, how they can finance a care manager in their practice. I really think that could be something that would most appropriately be done at the state level. I think it's too hard at the federal level, but some money to states to help them do that, I think would be really helpful.
So it's more than just if we provide the billing code, they will come.
Yeah, and I'm sorry, I got off topic, but I think the chart model is focused on communities, but I think that's one of the limitations, that it's not, broad enough in my mind.
So let me ask one last question, and then I'm going to kick it back to Richard for the final question. The participant asks whether behavioral health carve-outs are posing a particular challenge. This question specifically related to, in the context of Medicaid, to integration, really making integration impossible. And so I guess I'd ask any of you to speak to the question of what the role is of the carve-out model in the context of efforts to integrate primary care.
Yes, they are. Next question. Just kidding. Go ahead, Bob.
No, I think what carve-outs largely did is it put the burden of delivering most of the mental health issues on me without any payment for it, and left the patients largely with having to call and get connected to someone they have no natural connection to, no relationship, who is focused solely on that issue. The carve-outs were devastating. And I think they made care a lot harder in most cases for us. And we felt quite cheated by it, because we were still caring for the people's mental health issues, but weren't allowed to even put the diagnosis code down.
I'll just add to that, in as simple a terms as I can think. It is incredible. It's incredible to me that it's 2020 and we still live in a world where a little under 50% of states have some kind of carve out in the Medicaid program for behavioral health, LTSS, or something else. I mean, the premise here is, if the science and the evidence tell us that to maximize a person's health, we have to think across the biopsychosocial continuum, that we would partition or bifurcate payments and give different non-connected entities stewardship over those resources, and in some ways a bit of a disincentive to be collaborative with their data, that we're going to get better outcomes. I am a big believer, you've probably heard the echoes of it, and I tip my hand. I am such a big believer in incentives and the economics that drive incentives in our system. And for as long as we continue to treat behavioral health as some separate set of things we can pay for and support through a separate stream, through a different entity and a different network, and that the physical health of a person can be taken care of on this side, and the patient's going to figure out how to coordinate their activities between the two entities, we are leaving taxpayer dollars on the table, full stop. And all the money in the world could be poured into that system. It's still not going to be enough.
Back to you, Richard.
Okay. I think we're almost at wrap-up time. I'll just put down one thought for people to think about on the way out, and if somebody feels really moved right now to say something about it, that's fine, which is we haven't talked about what the behavioral health system needs to do, or what the provider system, everything that we've talked about today has been done to us. And so my question and my thing that I'd like to think about is, what do we need to show in terms of accountability systems, sort of along the lines that Kirsten mentioned, in order to convince people that they'll get what they pay for? And then the second is, how do we need to change the culture? Recall the literature is filled with little studies that show that the amount of time that it takes for a primary care doctor to change the subject when a behavioral health issue is raised is about a minute. And that isn't what's going to get us there. So I think accountability and culture work are very important to move the ball forward here. And I'll stop there and let whoever is going to wrap up.
I think at this point, thank you, Richard, and thank you to the entire panel. This was fantastic, and we so appreciate all of your expertise. And I'm going to kick it to Deirdre and Ruth to take us home.
Ruth? Hi. Do you have comments?
I just wanted to take this moment to thank everybody for this series of webinars, and for the speakers, the moderators, and the attendees for all of these sessions, for all 3 of these webinar sessions, but particularly for the conversation that we had today, which was so rich and hopefully helps us to move forward in the much of the work that we have to do. So I'm going to pass it over to Deirdre for some final statements.
And I'm going to be a little redundant, but thank you, Richard. And again, I'd like to thank all of our distinguished panelists, including for session 1, Drs. Colleen LaBelle, Phyllis Foxworth, Carla Cobb, Stephen Andersma, and Perinda Khatri. And for session 2, Drs. Robert Phillips, Sharon Reif, Kirsten Baronio, and David Smith for their very thought-provoking and stimulating presentations. Our session moderators, Drs. Alexander Ross and Richard Frank. Our forum chairs, Drs. Colleen Berry and Howard Goldman. Co-chair of our webinar planning committee, Dr. Ruth Shim, and all members of the planning committee. The National Academies of Sciences staff leads, Laureen Gregg, Caitlin Friedman, Anicia Welks, and the entire team at NAS. And a special thanks to our audience for joining us today. It has been our great pleasure to present this series of webinars on caring for people with mental health and substance use disorders in primary care settings. Links to the video recordings of the first 2 webinars are available on the NAS webpage, and the link to today's webinar will become available by Monday, August 31st. A few days ago, when I was speaking about the webinars with a dear friend who happens to be a retired mental health and addiction professional, she said, "Oh, well, we were talking about integrating primary care, mental health, and addiction services 40 years ago." What was not spoken but clearly implied was the question, what makes you think that all your talking is going to translate into meaningful action this time around? What is your X factor? Well, my X factor is everyone who has participated in these webinars, the collective enthusiasm, experience, and wisdom you have brought to these discussions, our audience numbers suggesting that we have at least a critical mass of people with the requisite knowledge, skills, and motivation to make meaningful and lasting changes in our systems of healthcare. And finally, my X factor is this moment in time, the urgent need for transformative change in our healthcare delivery system in the setting of today's multiple converging public health crises. It's hard to imagine how we could possibly overcome these crises and move forward as a society in the absence of profound changes in our systems of healthcare delivery. The times are compelling us to act in ways that we've never acted before and will continue to do so for some time to come. And I believe, based on the energy and insights that all of our speakers and all of our audience members have brought to these discussions, that we are more than well prepared to meet the challenge. Our fondest hope is that all of us will continue these powerful and transformative conversations well beyond this series of webinars, in keeping with our sure understanding that optimal mental health is foundational to optimal physical health, and encouraged by our faith that by working together across differences in professional disciplines, across disparities in resources and other would-be barriers, we can transform the delivery of health services in the US in ways that will strengthen our communities and families for generations to come. Thank you for your unwavering commitment to the cause of improving care for the whole person, which is key to restoring the health of our society. You are the champions, the sheroes, and the heroes. And as always, we wish you continued safety, vibrant health, and peace.